It's a better way of assessing people.
Of course.
Yeah.
You get to know how much the person has worked.
Yes.
Good evening, Senthil.
Dr. Senthil Nathan has joined. Very nice.
Yes, sir. He was kind enough to accept our invitation.
So Kanakavelu is raising the standards also now for the
It is now 4 or 5 months for the young ones, sir. Now we should have more senior faculty so that the questions also go up. I was waiting for Probal sir to finish the RRC work. So moment he finished, I requested and he immediately agreed.
Yes, sir.
And now we, as everybody suggested, one specialist we'll have amongst the 4 faculty. We'll have, so it becomes easy for us to raise the quotient and standard.
In fact,
good evening, everyone. Now we are
Dr.
live on
Kanagul,
YouTube. Sorry, sir.
I attended one meeting of this oncosurgeons.
Yes, sir.
They have a class, and then they have a CME related to that class. From the top, they have a case presentation.
Yes, sir.
Then they have a CME related to that topic by a senior surgeon who gives takes an overview of that topic, which is very nice. Which was very nice way of doing it.
Sir, Kanakvel, what sir is trying to tell is like this.
Yes, sir.
One person will, we have done it in Manipal sometimes.
How do you do it, sir?
Person will speak for about 25 minutes on carcinoma stomach.
Okay, sir.
Whatever important parts only, not etiology, pathology, and all that things. Which students can read anyhow, but the important things are the clinicals and inspection, investigation. It is immediately followed by a case of carcinoma stomach.
Okay, sir.
Immediately followed by case of
actually, sir, in Chennai we are just now starting the PG CME in general surgery. So at this point we are trying to unify all the institutes in Chennai. Last week we had thyroid. Next month we are going to have a CA rectum. We are trying to have a separate PG CME, sir, but this format, let me try in one of the classes, sir. We can have the senior invited faculty to give us brief talk before starting. Then the PG can go for presentations. We'll try, sir. We will try.
Or vice versa. They present the case.
Yes,
and
sir.
Then he summarizes everything and says, this is important for this case.
Sir, actually, sir, this time itself, we will limit the clinical presentation to half an hour, 15 minutes, evaluation and management. Last 15 minutes we'll dedicate for the surgical aspects and complications, sir. We will plan that way. We will work out, sir. We will try to bring the change, how we are able to do it. Then we will slowly raise the tab, sir. The CME part, I think we will have, sir, as everybody suggested, one of these coming week. Maybe I will request our scientific committee members to give a talk so that we will know how it goes. Then once we feel things are going good, then we will bring others. What is that want to share, Rajgopal, sir?
Nothing. I'm not sure about the opinion of others here.
Yes,
this is 8 to 10 is something. 8 to 10.
What time do you want to have, sir?
No. That's why I'm just asking all others who are in the forum. I'm not sure whether it is 7 to 9 is okay or
6 to 8. 6 to 8.
Because the problem is, I'm not telling that you are particular about dinner or something like nothing like that. But you see that 9 to 8 to 10 is something, you know, which is it is somehow.
I think Kanna sir is also there. Should you want 9 to 11, sir? Maybe what is that you want to have, sir?
Take a call from the most of the people who are here and then take a decision.
You feel 8 to 9, 8 to 10 is midway between this and that, you feel, sir? So actually, I didn't want to clash with the ASI program. They've been doing 9 to 11 for quite some time, almost now 6 weeks of continuous deliberations. Now they are completed. Either we can switch over to 9 to 11, that is a possibility, so that everybody would have finished the dinner by then. Sir, let all the faculty guide me, sir. I am willing to listen to.
I mean, it is not just it's for the people to decide. It's not that so convenient time, which is probably.
Sir, I would request one more week you bear with us for this 8 to 10. Sir. Let us mature out of it, sir. Then we will definitely swap to either earlier or later, sir. I am fine for the change, sir.
Kanakavelu is like a strong horse, like a workhorse of petrolized major myocarditis flap. He is ready for anything.
Sir, not really, sir. Ultimately, academics should win. That is all, sir. No egos or nothing.
No.
Since the normal routine has started, sir, 5 to 7 is not a very good time, sir, because I could not
attend any. Good, Prabal, sir.
I agree.
ASI time was actually quite good. 9 to 11, when you finish your dinner and you can sit down and then maybe do it. I don't know.
Sir.
But depends on others. I am comfortable with anything after 8.
Anna, sir, what is your thought, sir?
I thought probably 8 to 10, Jay.
8, yes.
Yeah.
Jailal, sir. Now you are going to work 24/7 for another 360
Jailal, sir, congratulations. I forgot to congratulate you, sir.
Thank you, sir. Thank you, sir.
Congratulations, sir. Yes, sir. Congratulations.
I think Vivek sir is also there. Then I will anyway. The coming week we'll have 8 to 10. Sir. Then we will try to see how the feedback and then we will change that.
Sure, sure, sir. That's fine. That's fine.
Thank you, sir. And on behalf of all the faculty here and the invited faculty, I wish all the participants a happy festive season. We have festivities coming up, Diwali and then Christmas. I trust by the time New Year, we have new vaccine for all of us so that we can get back to work. I hope, I think we are getting positive signs everywhere, like vaccines are getting approved. So with that words, we are going live on the YouTube channel. So now we have 2 presentations. Before that, I welcome the day's faculty. We have Professor Prabal Neogi from MLN Medical College, Prayagraj, sir, and a senior GC member and an active academician. He has been with us for a long time, and now he had the responsibility of ASI RRC, and he is now back with us. Number 2, we have Dr. Sendil Nathan, sir. He is the faculty of the DNB GI surgery program, and DNB GI surgery in GEM Hospital is senior to many MCH programs in the country. And they have been pioneering in teaching DNB GI surgery and as well as the FNB program. And of course, they were also taking the non-conventional fellowships, and they were very open for any student. And I'm sure all of us would have at some point of time visited their center for a few days to learn and update. And they have been always willing to welcome people. Thank you, Sendil Nathan, sir, for academic contribution. Now,
thank you, sir. Thank you.
We also have Professor M.J. Paul. Professor M.J. Paul is the current president of the Indian Association of Endocrine Surgeons, and he heads the endocrine unit. He's a professor of surgery at Christian Medical College, Vellore, and he also heads the endocrine surgery part of CMC Vellore's general surgery unit. So Paul, sir, is also having academic commitments in the college, administrative commitments. So he will finish the meeting and he will join shortly. So we have 2 PGs. One has been given by the Gujarat Surgical Society. I think credits to Andarya sir, Modi sir, and Shah sir for giving us the candidate. We have the postgraduate from BJ Medical College, Ahmedabad, for today's presentation, Dr. Densi Hansalia. And then, in fact, I should also put on record and thanks to Dr. Rajgopal sir. Last week itself, he gave the PG, and then by then we had the case, so I had to request him. We had the thyroid case given by Dr. Rajgopal sir. Thank you, Rajgopal sir, for allowing us the PG. Now, without much delay, I will request the first candidate from BJ Medical College, Dr. Densi Hansalia. Can you switch on your video and start sharing your screen? Please introduce your chief and then you start your presentation. So we will have the presentation and other things finished in half an hour, 15 minutes of management, and then 15 minutes of operative surgery and complication. Like that, we will try to experiment. Over to you, Dr. Densi.
Your device is ready.
Good evening.
Go ahead,
Hello.
Densi. You're okay.
Yes, sir. Yes, sir. Good evening, everyone. I'm Densi Ansalia from BJ Medical College, and I'm presenting a case of epigastric lump. Under guidance of Dr. P.R. Modi sir, Dr. N.M. Parmar sir, and Dr. D.M. Parmar sir. A 42-year-old male patient residing in Ahmedabad, laborer by occupation, chronic alcoholic, presented to OPD with chief complaints of upper abdominal pain for 2 months, upper abdominal swelling for 1 month, and vomiting before 1 day. Patient was relatively asymptomatic before 2 months. Then he developed severe upper abdominal pain radiating to back, continuous, aggravated by taking meals and associated with nausea. Patient was admitted in a private hospital for the same and treated with medications. Pain was resolved in 5 days and then the patient was discharged. Since then, the patient has on and off mild upper abdominal pain after meals associated with early satiety, not taking any medications for the same. For 2 months, then he developed severe upper abdominal. The patient noticed a swelling in upper abdomen before 1 month. Half the size compared to present size were noticed and gradually increasing to present size. The swelling is painless. Patient complains of vomiting before 1 day after he took heavy meal, the vomit is containing food particles. There was no history of fever, icterus, change in bowel habits, change in color and consistency of stool, blood in vomiting, significant change in weight and trauma. No significant past history, no significant family history. Patient is on mixed diet, alcoholic for 25 years, taking 2 drinks a day. Bowel and bladder habits are unaltered and sleep and appetite unaltered. Summarizing my history, a 42-year-old male chronic alcoholic with an episode of severe upper abdominal pain radiating to back before 2 months, which resolved, and having on and off upper abdominal pain with meals and early satiety since then. Patient noticed a swelling in upper abdomen 1 month back with 1 episode of vomiting 1 day back associated with intake of heavy meal. No other significant history.
Faculty can ask questions pertaining to the history part, sir. Central sir and Prabhat, please take it.
Good evening, Dr. Dempsey.
Good evening, sir.
So he's been alcohol for 25 years.
Yes, sir.
Was there any previous such history? It's like
No, sir. No past history of similar complaints, nor the history of repeated admissions.
Right. Was there any weight loss?
No significant weight loss, sir.
And what are the other things you wanted to ask? So based on the history, only history, what are the things that comes to your mind?
So based on the history, I would like to think that the patient had an episode of acute pancreatitis before 2 months. So I would probably consider this to be a pseudocyst of pancreas. And to rule out that, I would like to ask for the negative complaints, that is fever, icterus, change in bowel habits, change in color and consistency of stool, blood in vomiting, significant change in weight, and any history of trauma if present.
Okay, pancreatitis, yes.
Yes,
we
sir.
can fit in. Any other diagnosis before you move on to the examination?
Sir, considering the acute pancreatitis episode, my diagnosis might be cystic swelling of pancreas, sir. Malignancy of pancreas cannot present in such a short duration.
Nancy, what is the total duration of the disease?
So 2 months.
Okay. So if you get a swelling after an acute attack of the pancreatitis, you think, what are the various causes of the swelling which may occur in the upper abdomen?
Yes, sir. It may be acute fluid collection, which may occur within 4 weeks. It may be acute necrotic collection, if the necrosis is present.
No, don't assume that it's pancreatitis.
Okay, sir.
What are the other conditions which will produce a lump in 2 months with pain?
Sir, it may be liver abscess. It may be retroperitoneal cyst.
No, in this case, don't give no fever, no icterus in this case. Now, don't give all congenital, inflammatory, and malignant causes. Just give what could be the other things in this case.
Pain with cystic swelling. I would like to go for swelling.
How do you know cystic swelling? No. How are you assume by history that cystic swelling?
No, it is just a swelling. Yes, sir. Sorry, sir.
Just a swelling.
Yes, sir.
Swelling, epigastrium and vomiting. What do you think it is?
Swelling, mass arising from this stomach, sir.
Right.
Yes, sir. Mass arising from left lobe of liver.
Okay.
What swelling arising from the stomach mass can give rise to pain in the back?
Sir, the carcinoma of the stomach, which may be impinging over the retroperitoneal structures,
Don't go on
might cause
using
pain in the back.
Don't go on using the wrong word. Impinging is different from infiltrating.
Infiltrating.
I will ask you another leading question. Can you have a carcinoma stomach with a small perforation?
Yes, sir.
Is it possible in your patient? He has taken alcohol.
Yes, sir.
He's been drinking.
Sealed off gastric perforation may lead to swelling associated with pain. Yes,
So
sir.
we would like to ask you in that direction. Yes, perigastric collectants, small perforation,
Yes,
small perforation anteriorly or posteriorly. It can posteriorly be as good as a concealed lesser sac collection only.
Yes,
What is lesser sac means? What is lesser sac?
Sir, lesser sac is a potential space. Yes, sir. It is in posterior to the stomach.
So posterior gastric ulcer perforation with a small collection. It's also a known entity in the complications of peptic ulcer, is it not?
Peptic ulcer disease. Yes,
one
sir.
possibility. I just want to ask you, can it be acute on a chronic pancreatitis?
Yes, sir.
Yes.
It can be acute on chronic pancreatitis, but the patient does not complain of prolonged history of abdominal pain.
That's why you should not get swayed away by examiners.
Don't agree to everything what people suggest.
You only said it's only 25 years of alcohol, but only 2 months duration. So based on the history, it's very unlikely it can be an acute or chronic pancreatitis.
Yes, sir.
So don't agree to I mean, probably they may. I mean, the examiners may sometimes, not always. Sometimes we may lead to a different area, but you should be strong enough in very, very obvious things. Only 2 months out of 25 years. So it cannot be an acute or chronic pancreatitis because no previous admissions, no pain. So what I was expecting other than the pancreatitis, as Sir was telling, is acid peptic disease and its complications. Patient had vomiting, it can be gastric outlet obstruction. And swelling is based on the history, is a vague symptom. A fullness, people can say as a symptom, I mean, as a swelling. It can be an epigastric hernia, people can also say, a swelling. So based on the history with a swelling in the epigastrium, we have to be very cautious. Even a general distension, people can say there is a swelling in the abdomen.
Yes, sir.
I think you should also think of the cholecystitis. Whenever there is a pain in the upper abdomen, which is there with a lump in that area, you have to think of 2 or 3 possibilities which are there. Is it from the pancreas? Is it from the stomach? Is it from the gallbladder? Or is the retroperitoneum there? So these are the few common things which are there, which you will be coming in that area there. So all these possibilities should be kept in mind.
Yes, sir.
And even an epigastric hernia.
Yeah.
And see, you said there is a early satiety. And how do you explain that?
Sir, because of the compression of the swelling over the stomach, or there may be the origin of the swelling from the stomach itself. Both these possibilities can lead to reduced capacity of the stomach for the meals. This may lead to early satiety, sir.
So patient has, but you said there is no change in the bowel habit. So when you suspecting there is a obstruction, early satiety, that means there is no change in the bowel habits?
Sir, as such, patient does not complain of constipation, neither of diarrhea. So that does not change the bowel habits, sir. But the patient has early satiety, but he can take frequent meals. So as such, patient have adequate diet.
A change in bowel habits is, it includes upper and lower symptoms as well.
Both the symptoms?
Yeah, both the symptoms you have to, probably, yeah. What you mentioned is constipation as diarrhea is lower GI symptom. Upper GI symptom like bloating, belching, early satiety, again, if there is such symptoms, then you have to put it as the change in bowel habits. Is in the category of upper GI symptoms.
Okay, sir.
So when you call someone as an alcoholic?
Non-social drinking and frequent.
That is only a habit of drinking alcohol. That is not alcoholic. Alcoholic is a disease.
Yes, sir.
So it has
cage.
definition for alcoholic. So only when they have this, if they are having symptoms physically dependent on alcohol, then
Physically dependent. Yes,
only you
sir.
must call them as an alcoholic. Otherwise, it is better to say they has a habit of taking alcohol.
Okay, sir.
You can go on the examination now, yeah.
Okay, sir. On general examination, I have examined my patient with informed consent in adequate daylight. Patient is conscious, oriented, fairly built and fairly nourished. BMI is 22. Patient is afebrile. Pulse is 74 per minute in right radial artery. Blood pressure is 122/84 mmHg in right brachial artery. No icterus, pallor, edema or lymphadenopathy noticed. So this is a photograph of the patient in per abdomen examination. On inspection of the abdomen is flat, umbilicus normally located and inverted. 8/6 centimeter size swelling is visible in epigastrium, extending into umbilical region, not moving with respiration, with overlying skin being normal. Skin of the rest of the abdomen is normal. No scars, sinuses, visible peristalsis, visible pulsations. On palpation, abdomen has normal temperature with no tenderness. 8/6 centimeter size intra-abdominal swelling is palpable in epigastrium, extending into umbilical region with normal overlying temperature. The swelling does not have tenderness with smooth surface, firm consistency, and well-defined margins. It does not move with respiration. Transmitted pulsations over the swelling is present. No other palpable swellings. On percussion, liver span of 11 centimeter is present in mid-clavicular line. Resonance is present over the above mentioned swelling. On auscultation, normal bowel peristaltic sounds are heard. Inguinoscrotal region, hernial sites, and back and spine are normal. Digital rectal examination reveals no abnormality. Left-sided supraclavicular lymph nodes are not palpable. Respiratory, cardiovascular, and central nervous system reveals no significant finding. On summarizing, a 42-year-old.
Then before summary,
yes,
can you go back to the palpation?
Yes, sir.
Yeah. You have not mentioned the extent of the swelling, extent of the umbilical region, but can you able to insinuate the finger between the swelling and the costal margin?
Yes, sir. I was able to insinuate the finger between costal margin and the upper border of the swelling, sir.
That you should mention.
Yeah.
Okay.
So because it's very important, no? Why it is important?
Why is it important?
Yes, sir. To differentiate between if the swelling is arising from the liver or from the stomach or pancreas.
So it's always important to remember upper abdominal mass, upper border, lower abdominal mass, lower border.
Yes,
is it palpable or can you insinuate the finger? Because obviously female patient, pelvic tumors, ovarian cyst, uterine mass. So that is why in the lower abdominal mass like a right iliac fossa,
yes, sir,
there is some lot of noise is coming.
What do you mean by abdomen is flat in this case? Because you have mentioned this abdomen is flat.
Sir, abdomen is flat is a normal, fairly built patient or fairly nourished patient. It is neither scaphoid nor distended.
No, we are not asking that theory. In this case, you are looking at the abdomen and you are saying that it is a flat, and then you say there is a mass.
Yes, sir. Except the mass region, the abdomen is flat. I inferred that, sir.
So what you should tell in that situation? Better not use the word flat at all. The abdomen is distended in the upper abdomen. Enough.
Visible distension in the upper abdomen.
Or a bulge.
Bulge in the upper abdomen. Yes, sir.
So, Jency, I think your examination of abdomen is inadequate. Right?
Okay, sir.
Right. I'll tell you the points which you are missing. First, you give the liver span. Percussion, is the lump percussion continuous with the liver or not? Right.
No, sir, it is not continuous with the liver.
Is the pulsation visible or not? Is there a transmitted visible pulsation visible or not?
No, sir, pulses are not visible.
You have to mention all this. Is there free fluid there or not? Can you insinuate your fingers there or not? Does the lump move down on respiration, on valsavas, on exertion? You have to mention all this. It is important here, right?
So, how did you say it's an intra-abdominal lump?
Sir, to differentiate from the parietal swellings, I asked the patient to lift up the both lower limb, that is like raising test. Then that is called the Carnot's test. And the other test I would like to do for that is ask the patient to lift up the head, that is head raising test. In both of the tests, if my swelling becomes less visible, less palpable than before, then I would like to intra-abdominal swelling. Yes,
you were able to appreciate in this patient that this is an intra-abdominal lump?
Yes, sir. I could easily differentiate between the parietal swelling and the intra-abdominal in this patient. This was definitely not parietal.
No, there are three types of swelling. One is the parietal swelling, another is intra-abdominal swelling, and third is the retroperitoneal swelling.
Yes, sir. This patient, I have not done knee elbow position test, so I could not differentiate between retroperitoneal and intraperitoneal.
So what can you do then to differentiate the intra-abdominal and retroperitoneal swelling?
Yes, sir. For that, I would like I would first palpate the patient in supine position. After that, I would like the patient to go into knee elbow position.
Other than knee elbow, we said knee elbow is not done. Any other method?
Sir, if the mass is moving on respiration, then it is definitely
mass is not moving. We just wanted to know how differentiating between intra-abdominal and the retroperitoneal position. Intra-abdominal versus retroperitoneal without doing a knee.
Any better option of knee elbow position testing?
Sir, on the lateral position, I would like the patient to in one of the left lateral or right lateral position, and if the mass or the swelling falls forward, it is said to be intraperitoneal, and if doesn't, it is retroperitoneal.
Yes, you can do that. And what are the swellings in the epigastrium that move on respiration? You said this does not move on respiration, so you can exclude a few things, isn't it? So what are the swellings in the abdomen in your case, do you think, that would move on respiration?
The swelling arising from liver, the swelling arising from stomach, the swelling arising from the spleen moves with respiration. If large swellings which appear to be in epigastrium, definitely.
Why they move? Why the stomach is moving on respiration? So any structure which has why the structure is moving? Stomach is moving on respiration.
Sir, because of the movement of diaphragm and those structures which are in contact with the diaphragm moves, sir.
Okay, so any connection with the diaphragm, then it will move.
Yes, sir.
Then see, another thing which I wanted you to mention is visible gastric. This could very well be a dilated stomach, what you see.
Yes.
Right? Sir. So I wanted you to specify that there's no visible gastric peristalsis. All this has to come. You have to map the stomach using your auscultation and percussion. All that has to be done because this upper abdominal epigastric swellings are features which have to be distinguished from other structures so that you can come to a diagnosis just by examination. Right?
Yes.
And examination. Yeah. Then see, this large swelling is pulsatile, means I am telling, using the word large swelling is, you see pulsations, means what do you suspect?
Sir, this patient's swelling does not have visible pulsations, but
sure.
On palpation.
No. If this patient shows pulsations, what do you suspect? You don't have to get worried too much. You keep your diagnosis in mind only and answer.
Sir, that may be the transmitted pulsation from the underlying aorta.
That is the important sign to differentiate from a liver pathology. You understand, no? Sometimes you'll find a large cyst very close to the diaphragm, pseudocyst only, very close to the diaphragm. Even if
with respiration.
Limited with respiration, even insemination may become difficult. Closely differential diagnosis of liver cyst, then that percussion will help you. Remember, you are asked percussion, and then transmitted pulsations will help you. Okay,
yes,
right.
How could you say it is a transmitted pulsations? How could you say it is a transmitted pulsations?
Yes, sir. On examining, I would like to place my 2 fingers over the swelling, and then when the pulsation occurs, my 2 fingers will move either apart or either both the fingers will stay together and move upwards. If they are separated apart, it is transmitted pulsation, and if they are moved upwards together, it is expansile pulsation.
Is that true for the abdominal swellings also like this? What you are telling is that true statement for the abdominal swellings? It is okay for like if the radial artery is there or in the limb is there, it is okay for that. But such a big lump which is there.
And do we really do it practically?
No, sir. Sir, I would then confirm that thing by knee elbow position. In that, if the pulsations are transmitted pulsations, it would disappear. And if they are expansile pulsations, or obviously writing from the artery, it will stay even after the knee elbow position.
Yeah, I think that should be your answer. But you know, normally we do not do the things in the knee elbow position. But otherwise, if you want to give the answer, that is the answer. That you will take the patient in the knee elbow position and see that what is happening to the person.
Yes.
Right. Shall we move ahead and
you said it is a resonance, no? By percussion.
Yes, sir.
Is it as resonant as the bowel, or it is an you qualify it as an resonance, or it is an impaired resonance or altered resonance?
No, sir, it is resonant because of the gas in the.
But there is a large fluid. You said you tentatively your diagnosis. You said a cyst.
Yes, sir. But the resonance is because of the overlying stomach, sir.
Have you seen the CT scan of any pseudocyst or barium meal of any pseudocyst?
Yes, sir.
You see a dilated stomach over there?
Not a dilated, sir. Collapsed stomach.
So?
Because of the compression.
So there is no air.
That is impaired resonance, sir.
So if the entire stomach is really displaced, it may be even dull also, because there will not be any air also.
Yes, sir.
Even swallowed air is the one thing also will be missing, right? So, but in some cases, stomach will be anterior. You do get some kind of a impaired resonant note. So that is little explanation like that. Yes.
Shall we move?
Yeah.
Yes, sir.
What's your summary and what's your diagnosis?
On summarizing, a 42-year-old male, chronic alcoholic, presenting with an episode of severe upper abdominal pain radiating to back before 2 months, which resolved, and from then having on and off upper abdominal pain with meals and early satiety. Patient noticed a swelling in upper abdomen 1 month back when one episode of vomiting 1 day back. On examination, there is a 8 by 6 centimeter size intra-abdominal swelling, palpable in epigastrium, umbilical regions, non-tender with normal overlying temperature, smooth surface, firm, with well-defined margins, not moving with respiration, and with resonant note on percussion. From this, I would like to put my provisional diagnosis as pancreatic pseudocyst.
Right. Why? What are the points in favor and what are the points against your pseudocyst?
Sir, my patient is a middle-aged male with chronic alcoholic. Patient is alcoholic with an episode of acute pancreatitis before 2 months. And on examination also, the swelling is firm in consistency in epigastrium, arising from epigastrium, extending into umbilical region, which is smooth surfaced. I can insinuate my fingers between the costal margin and the swelling.
That goes against that insinuation of the finger, which is usually not possible in pseudopancreatic cyst. Usually, if it's a lesser sac swelling, you cannot insinuate your finger. That is the point against your pseudopancreatic cyst diagnosis. Right. Okay. What else?
There is well-defined margins is present, and there is transmitted pulsations present, resonance resonant note over the on percussion.
When well-defined margins, it is very difficult to get in all pseudocysts.
And is there any other diagnosis in your mind
Exactly.
other than pancreatic pseudocyst?
So from the history, I would not like to make any other.
No, history examination both now.
Except backache.
Yes, sir, on history and examination.
Except the history of backache, you don't have any evidence to say it is a pancreatitis. The history.
Yes, sir.
And even the history of pain hasn't been a very severe pain because we are still not sure whether this patient is, because alcoholic, you are mentioning alcoholic many times. So is it a chronic alcoholic with a chronic pancreatitis with an acute exacerbation, or was it the first time acute pain that happened, or is it anything other than that related to an alcohol use? Could it be a liver tumor?
So the liver tumor definitely would move with respiration, and in such cases, the swelling appears even before the pain episode.
And could it be any other swelling arising from the stomach?
Yes, sir. It can be the sealed off gastric perforation, as we talked before, sir, presenting with acute pain. After that, the swelling appears.
Other than that.
Other than
anything else?
Other than that, sir, patient may be having carcinoma, this swelling in the pyloric region, which may be causing the early satiety and complaint of pain.
Something similar to this in the ball from the stomach, it is coming.
Other tumor?
In this age, sir.
Yeah, please go ahead.
Sir, at this age, sir, omental cyst is not likely. It may be in the younger patients.
You've
From
got a
stomach.
hint. Tumor. You've got a hint. Senthil said that it is from the stomach.
Only from the stomach.
Cyst tumor, but that is a pathological diagnosis. So I cannot.
Still, yeah, pathological diagnosis, but still it can be present as a lobular swelling, firm in consistency. It need not move with respiration, especially if it's lying along the lesser curvature. You can able to insinuate the fingers. So yes, though it's a pathological swelling, GIST can present from a small innocuous lump to very large lump. So nothing wrong in because GIST is distinctly separate from adenocarcinoma of the stomach. So you can give it as a differential diagnosis also. In fact, I would put this number 2 diagnosis as GIST.
That is very, very right.
I would also do the same.
Then see any other characteristic feature GIST may have compared to a cyst like this, pseudocyst or something. Any between, okay, I'll put it other way. Carcinoma stomach, there is a mass, and the GIST, there is a mass. Any difference is there? You understand?
Sir, yes, sir. Sir, the gastric outlet obstruction would not be present in.
No, don't bring it. I just want to say mobility. You understand?
Mobility.
Why?
Yes,
why GIST have got characteristic mobility? Very, very mobile.
Yes, sir. Very mobile.
Why? Because
it is a submucosal tumor.
So it is more growing outside than inside. Is it clear?
Inside, yes, sir.
Exophytic lesions, often they will have a characteristic mobility. Stomach will tend to infiltrate the layers. Stomach mass becomes comparatively smaller one. By the time they come, they are infiltrative nodes there, omentum. So obviously some amount of restricted mobility, especially from the body, right?
Yes, sir.
And how about cystic neoplasms of the pancreas?
Yes. I think I thought I would have probably given that, sir, as nearer to this diagnosis, because we are anatomically thinking in terms of a pancreatic pseudocyst here, which features suggestive of not moving with the respiration, not getting all that thing. So nearer probably, but for male and alcohol, otherwise.
Against, let her answer. What are the points against cystic lesion of the pancreas? Cystic neoplasm.
So first of all, the short history.
No. First,
And
start from. He's already told you the answer. He should have caught
yes,
on.
sir. Sir, alcoholic patient and the male patient.
Male patient.
Then male patient. Yes,
Number
sir.
one. Then
Patient is chronic alcoholic. Then this patient has a very short history. Patient having severe upper abdominal pain, which is as such not seen in cystic neoplasms. And there may be pain in cystic neoplasm, but those appear later on. So the patient might be having the complaint of swelling even before.
Do you know that some of the cysts are confused for pseudocyst and treated mistreated?
yes.
It is possible.
Pseudocyst. Yes,
No. Cystadenomas and confused for a pseudocyst, and
yes, sir.
when they were trying to surgery, there is a problem.
So how can you differentiate? So let's go on to our differentiation. We already now 40 minutes into our history and examination. So how would you distinguish this? You think it's a pseudocyst. Now I say that it's a cystic neoplasm. How will you going to differentiate the two?
Sir, I would like to go for endoscopic examination of that cystic fluid. That would be the confirmatory finding. Other than that, before
this, you have a patient who's come with the swelling in the epigastrium. You're going to go in for an US first away. Like, what is your basic investigation?
So first of all, I would like to do routine investigation, routine blood investigation, along with that serum amylase lipase level.
You want to confirm the diagnosis, most probable diagnosis. What is your first advice when this patient comes to your houseman to confirm that this is
ultrasonography?
Yes.
Yes,
so
sir.
Say that. So what will you see in ultrasound?
Sir, ultrasonography, I would like to see the characteristic of the cyst, then the organ of origin of the cyst, then the surrounding organs, along with that ascites and lymph nodes.
Right.
In the characteristic of the swelling, I would like to see whether the cyst.
So the report comes out as a large cystic lesion in the pancreas, right?
Yes, sir.
And we know that the organ of origin is the pancreas. Now we're not sure about anything else. It is in the lesser sac, anterior to the pancreas. So now what do you do after this?
Sir, I would like to go for contrast enhanced CT of abdomen pelvis, sir.
What do you want to see in a CT scan, and what are you going to look for?
Sir, similarly, the characteristic of the cyst itself, whether the pancreas inflammation is present or not, the pancreatic parenchymal changes, the condition of the main pancreatic duct, its communication with the cyst if present, and liver, spleen, other organs surrounding it. There is a bowel and inflammatory lymph node surrounding that region.
What is that CT called? What sort of a CT are you going to do it? What is that called?
Sir, pancreatic protocol CT and
pancreatic protocol, right? Okay, you do that.
Yes,
what
sir.
is the pancreatic protocol CT?
Sir, in pancreatic protocol CT scan, there is a plain CT first of all taken. Then after contrast enhancement, I would like to take three phases, sir. Portal venous phase, pancreatic parenchymal phase.
No, please say it in that order. Does the portal venous phase come first?
No,
please
sir. The hepatic. Yes, sir.
So what is the order?
Sir, hepatic phase, pancreatic parenchymal phase, and portal venous phase.
No, it's the arterial phase, isn't it? The first is the early arterial phase.
Arterial phase.
What do you see in that early arterial phase?
Sir, in that I would like to see the pancreatic parenchyma.
No,
and its differentiation from the lesion.
No. Early arterial phase will not show up pancreas. After how many seconds is it done? The early arterial phase?
After 30 seconds, sir.
It's about 15 to 20 seconds, right? Straight away. If it's a 64 slice 3D, then it's about 15 to 20 seconds it is done. So what are you going to see in that early arterial phase? You can only see the vessels, right? Is that right? And then what is the next thing that you see? The next is the delayed arterial phase or an early portal venous phase, right? The same, both are same, right? And then what is the third phase?
Sir, delayed phase, sir.
Delayed venous phase, isn't it?
Venous phase.
When the blood goes into the hepatic veins. So it has got importance. This has got importance to see the parenchyma, the liver, the arterial system, the relation of the arteries to the cyst, right? So many things that is going to tell you. Okay, right. So now it's still not, sorry, yeah, Senthil, yeah.
Uh, First, a few tips with regards to the diagnosis, especially examined by the senior faculty as well as the examiners. Never give one diagnosis. Most of the examiners, they don't like one possible and probable diagnosis. However obvious it is, at least try to give two or more diagnoses, even though they may be, the probability of those diagnoses will be less. In medicine, nothing is 100% sure unless and until you investigate thoroughly. Based on the examination and clinical findings, you have put it as a pancreatic pseudocyst. It could still be maybe in less than 5% in this particular case. It could be a cyst, it could be a carcinoma, it could be a cyst, even a cyst. So for completion's sake, at least put two or more diagnoses, so that you also keep in mind the other diagnosis as possibility, so that it should not come as a total surprise. So that's one tip. The other thing is, when do you do an MR? Suppose you see a pancreatic, ultrasound shows lesion arising from body, head and body of pancreas with some internal echoes. When do you do? You said a CT with pancreatic protocol, and in pancreatic protocol, what's the slice? Yes, the timing you have shown, and Prabal sir has nicely guided you. What's the cut? At what intervals you make cuts?
Sir, 0.5 mm.
No.
Sorry, sir.
It's 2.5 millimeter and collimated to 1.25. That is, you make a 2.5 millimeter cuts and reconstruct to 1.25 millimeters so that you don't miss anything. In pseudocyst, it's not a problem, but in a pancreatic carcinoma head of pancreas, every millimeter counts, like port vein invasion, the relation of the tumor with the surrounding pancreas and the blood vessels. So more than any other organ, pancreas, along with the surrounding vasculature, has a few millimeter can make a difference. It's 2.5 millimeter cuts with 1.25 millimeter collimation. So that's exactly pancreatic protocol.
Suppose it is a pseudopancreatic cyst. What would you be interested in knowing in the CT scan? Suppose I agree that your diagnosis is pseudocyst. So what are you now looking for in your CT?
So the location of the cyst, it's
how is that important?
So the location, if it is nearer to the stomach, I would better go for, if I'm planning for operative intervention, it would be better for cystogastrostomy. If it is location
you can just say that it is in the uncinate process, the head, body, body and the tail of the pancreas. You can say that the location is important, right? What else are you going to see?
Sir, I would like whether it is communicating with the main pancreatic duct or not.
See the ductal anatomy, right?
Yes,
with this triple phase CT, you can make out the ductal anatomy also.
Yes,
that is important, right? And what is the third thing that you want to see?
And sir, I would like to see the vessels surrounding arteries and veins. That is the portal vein, splenic vein, splenic artery.
That will help you in when you are managing it. Would you like to see any necrosis inside it?
Yes, sir. If it is heterogeneous.
How is it going to change your management if you find necrosis inside? I tell him that this patient has 70% necrosis along with fluid collection.
Sir, I would plan, if there is necrosis is present, then it is more like a debridement procedure rather than drainage.
Would you like to intervene straight away?
No, sir. I would like to wait for at least 4 weeks for the resolution of the symptoms or the resolution of the swelling.
The message that I want to give is that if you have a WON, that is a walled-off necrosis,
infection,
right?
I would have air foci. Then it would show.
You will not try to intervene early, right? So you wait and watch. If the patient is asymptomatic, you can wait and watch. Can you tell me, differentiate classify the various fluid collections around the pancreas according to the revised Atlanta classification?
Yes, sir. Any collection within 4 weeks of the episode of acute pancreatitis is divided into two. That is acute fluid collection if there is no necrosis present, and acute necrotic collection if necrosis is present. Anything more than 4 weeks, if in case of no necrosis present, it is pseudocyst, and if necrosis is present, it would be walled off necrosis.
Right. So coming back to the CT, so you have got seen three things. One is the location, the other is the relation. Then you have seen whether necrosis is present or not. And what is the fourth thing that you would like to see to differentiate it from a carcinoma, the cystic neoplasm?
Heterogeneity.
The walls of the cyst, isn't it? What is the wall of the cyst in a pancreatic? It can be nodular, it can be irregular
yes, sir. Irregular or
it will change your management, isn't it? It's going to change your management. Right.
Densey, what are the common cystic lesions you have to differentiate from the pseudocyst pancreas? So, because cystic tumors are...
Yes, sir.
Now, right.
Cystic tumors.
Okay.
Yes, what are the major things that you want to differentiate? Pseudocyst on one side, the other tumors on the other side. What are the things? I will put it in a different way. What are the other tumors you want to exclude before you brand it as pseudocyst and go on for the management?
Yes.
Yes, sir. The cystic tumors of pancreas, those are the mucinous cyst adenoma or serous cyst adenoma or intraductal papillary mucinous neoplasm, and the cystic tumors arising from other organs in the epigastric region.
No, we are not talking about others. So what we are asking is the other cystic lesions, neoplasms of the pancreas.
From the pancreas.
So now CT says that you're not sure. We can't say it has got some nodularity in the wall. Now you're not sure again whether it's a cystic neoplasm or a pseudopancreatic cyst. Now what is your next step?
Sir, if there is a suspicion of malignancy or difficult to differentiate with the cystic neoplasms of pancreas, I would like to go for endoscopic examination with endoscopic ultrasound if required.
And do what?
Sir, then I would like to take aspiration from that cyst and would send the fluid for amylase level, for CEA level, and for cytology. And for genetic
fluid. You can see the fluid. If it's a mucinous fluid, right? It's high likely to be a neoplasm. Usually in pseudopancreatic cyst, you have a very clear, not a clear fluid. You don't have mucinous thing. Viscosity is important. The viscosity is important. Then you have to get the tests done. Amylase would be high in a pseudopancreatic cyst. It would be low in all the cystic neoplasms. Then you get a CEA of that done.
Yes, sir.
Any other tumor markers would you like to do in that fluid? You can do. You can do CA19-9. What that is? That's very theoretical, right?
Okay, sir.
Okay.
And if you see if you are planning for doing a cystogastrostomy, what are the other things you are going to see in the CT scan, Jay? Like we think the plan is to do a cystogastrostomy.
Yes, sir. Sir, I would like to see whether there is any necrosis present, whether there are any infective foci within the collection.
You're told all those things.
Yes, sir. Sir, the distance of the stomach from stomach wall, from the cyst wall.
Yeah, that's very important. Whether
how much?
Yes, sir.
How much?
Up to 2 centimeter. We can.
2 is a huge. 2 is quite large. It's less than 1, isn't it?
1 centimeter. Okay.
1 centimeter.
And you have to see whether your cyst wall is matured or not.
Matured, yes.
Yes, sir.
That's very important before you go for the cystogastrostomy. Now, can Nancy tell that what thing you will see better on the ultrasound rather than on the CT scan in a case of pseudopancreatic cyst?
Sir, gallstones.
So you have to mention about that because you will not see the gallstones in the CT scan. You will see the the gallstones in the ultrasound.
Ultrasound.
That way, ultrasound becomes very important to say whether it is biliary pancreatitis or whether it's alcoholic pancreatitis.
Alcoholic pancreatitis.
So now, okay, fine. We may take it forward now. We are running out of time. Now you know it is confirmed that it's a pseudopancreatic cyst, right? And now what will you do for this patient? What will you advise him?
Sir, as the patient has not is symptomatic at present, I would like to go for internal drainage, sir.
I'm saying that patient is having only early satiety, vomiting only once, 18 to 6 centimeter. I'm saying, can we wait?
2 months, only 2 months.
Only 2 months. And you also mentioned that patient is tolerating feeds, only small frequent feeds, but the quantity is not reduced. BMI is okay. So except early satiety, his patient is fairly asymptomatic. Then why should we go for a surgical intervention at this point in time?
Sir, we can wait up to 6 weeks for the spontaneous resolution.
6 weeks has already crossed. You said 2
No.
months.
No.
You're already into the 8 weeks. 8 weeks.
Yes, sir.
So
Sir, there is
rather, what are the indications for intervention in a pseudocyst or walled-off pancreatic? Both. You can answer it together. Indication for surgical intervention.
First of all, if the patient is symptomatic, another indication is the infection present within the cyst or the collection. And
when you say symptomatic, make yourself very clear. In case of a pseudocyst, it is the persistent vomiting. You understand?
Okay, sir.
Most of the time, their pain will usually, come down once the pseudocyst inflammation will settle down. It is the effect of the inflammation. Okay.
Yes, sir.
So what are the indications of surgery? In other words, when you would like to intervene in a pseudocyst?
Sir, after waiting for a sufficient amount of time, if the cyst is not resolving and the patient is symptomatic, either the infection is present or there is compression symptoms over the surrounding structures.
Yes, obstructive symptoms. And where does it cause compression to?
Sir, first of all, on the stomach, as we said, persistent vomiting. Another is on the biliary tree, which may present as icterus, and because of that, the patient might be developing cholangitis later on, where we need to drain. And that is the gastric outlet obstruction if it is compressing over the duodenum in the head of the pancreas if the cyst is present.
Yes. So indications for intervention is obstruction, gastric outflow obstruction, causing obstruction of the bile duct, pain, increasing in size, right, and infection. So these are the indications. Otherwise,
you mentioned persistent cyst. Persistent cyst per se is not an indication. Even 6 months later, if it was say 4 or 5 centimeter, and you are 100% sure it's a pseudocyst, you can really wait. So at the moment, there is no time limit for the. If it's enlarging cyst, yes. This month it's about 8 centimeter. Next month it's going to be 10 or 12 centimeter. Rapidly enlarging cyst is an indication, but persistent asymptomatic cyst per se is not an indication for surgical intervention.
I agree 100%. I agree 100%. And you have to keep an eye on the cyst. Maybe do serial ultrasounds and see whether the size is going down or going up. Right? And then it is this thing for indication. Okay, fine. Now I agree with you that this has gastric outlet obstruction features, and you want to intervene. What are the various ways you can intervene, and what will you do?
Sir, there is internal drainage and external drainage.
I'm asking you what you would do.
Yes, sir. Sir, I would like to do an open cystogastrostomy in this patient.
I would do an endoscopic. I would ask my gastroenterologist to do an endoscopic drainage.
Yes, sir. I can ask my gastroenterologist to do that. I per se do not know that thing, so I would like to do open cystogastrostomy.
So, in other words, what is the ideal treatment in a say the cyst which does not have causing much problems, right? And, with minimal symptoms like this, endoscopic
is preferred.
Exactly. Unfortunately, we are losing out the surgeons, but endoscopy is preferred method for this.
When do you consider, on what factors you consider surgical intervention is better than
first of all, when the cyst wall is farther away or not indenting over the gastrointestinal tract, then if there is a infection present in the collection.
First is yes, cyst is not approximating to the stomach wall. Then what are the other options? Surgery.
Sir, endoscopy, surgical.
Surgical. Why? What type of internal drainage you do then?
Sir, cystogegnostomy I would like to do after mobilization of jejunum.
That's fine. So yes, location away from the stomach is an indication for surgical intervention. Next.
Sir,
presence of more
when there is
necrosis.
More necrosis. Okay.
Though we can do necrosectomy by endoscopy, it's not as good as at the moment. Still we can do, but majority of the time, necrosis cannot. We can remove it completely in the surgical intervention, not in endoscopy.
Any trial that Senthil is saying, I agree with him that surgical is a gold standard as compared to endoscopic. Do you know of any large trial to the same effect which has proven this?
Sir, Panther trial.
Yes, the Panther trial.
Yes, sir.
The Panther trial has proven that still surgically this thing is the gold standard, but endoscopic is also can be done.
One more thing where surgery is preferable. What's that? Wall thickness.
Wall thickness.
More than 1 centimeter. Generally, endoscopy is. Laparoscopy. Surgical intervention is preferable. Why?
Sir, because the pigtail stenting which we are placing in the endoscopic method might not be able to sustain those thick walled cyst. Plus, there were high suspicion of malignancy in irregular thick walled cyst.
And one more thing, when you are decided to go for the surgical intervention, what would be, the investigations should be done when you do the investigations, like the CT, or when you repeat the CT before you take up the patient for surgery.
Sir, I would like the CT done within the 4 weeks of my intervention.
Right.
If it has passed the 4 weeks, I would repeat it again.
When? No. What I mean is you go inside and you don't find the cyst. You open, either you go do laparoscopy or open surgery, and then you don't find the cyst, or the cyst is regressed in size.
So first of all, that is the examination. If the examination we find that the swelling is reducing, then I would like to repeat the imaging study. Moreover, if the patient symptoms are relieving or changing with time, I would like the repeat.
Patient symptoms are not relieving. There is say 2 weeks back, there is a CT done, which showed a large pseudocyst. Here you are not, very obviously, there is not much of a difference in the examination. Initially also there is mild fullness. Now also that fullness is persistent. But when out opening, you don't see the cyst. What could be the reason?
So the rupture of the cyst.
Exactly. Yes. That's what I wanted you to answer.
Yes.
There may be rupture or spontaneous regression of the pseudocyst. So the investigations should be as close to the intervention as possible within a few days, and then so that there should not be any surprises. There may be regression or reduction in the size, or sometimes large pseudocyst can rupture totally, wherein the treatment is completely different. So we need to, at least a day prior or a couple of days prior, you have to do the the investigations. Even if you have done the CT scan a week back, it's always better that the day or a couple of days prior, you have to repeat the ultrasound to make sure that the size of the cyst remains the same, so that there should not be surprises.
Okay.
If there is a rupture and you find a rupture, cyst is not there, there is free fluid in the abdomen, what else, what you do then?
Sir, I would like to drain the fluid and send it for the amylase level to confirm.
During the surgery. Sometimes it can. Okay, that you can do it. Yes. What else?
Sir, the cyst, I would like to see the pancreas. I would like to see the location of the cyst as mentioned in my previous imaging study, which
cyst would have disappeared. Cyst would have disappeared. You will not see where exactly the cyst or where exactly the cyst position was. All you see is some engorged veins in the gastrocolic omentum. There are multiple free fluids with fat saponification of the omentum. So what do you do then?
Sir, other than drainage,
where you drain? Where you drain? Yes, drainage is good. Where you drain?
Sir, drain the lesser sac specifically, and obviously the intraperitoneal collection if present.
Yes, you have to drain both. The greater
Yes,
sac is the peritoneal cavity, and then you drain the lesser sac. In the lesser sac drainage, which route is safe?
So safer route is to go this from the mesocolon region, so transverse mesocolon.
Excellent. Right. Very good question.
Very good.
Very good answer.
Very good.
Yes.
Now I tell you that
omentum gastrocolic window is not safe because we don't know sometimes where exactly the greater curvature ends. Everything will be plastered. Transverse mesocolic window is an ideal thing where you will mostly hit the lesser sac without encountering any complication like vessels or the bowel.
Now this patient has, the same patient as Senthil has mentioned, has landed up into a pancreatic fistula from the drain. What do you do?
Sir, I would like to wait for some time for the spontaneous resolution of the pancreatic fistula.
What is the, how do you know that this is going to spontaneously close, or do you think this is going to continue? What are you going to do this now? I'm giving you chance of more investigations now. So this pancreatic fistula is there.
Sir, the pancreatic fluid amount, along with that, any fluid which occurs in the drain for more than 3 days of about amylase level more than 3 times the normal.
That is, you are talking about a leak in the ripples. No, we are not talking about that. We are talking about, we know this is a pancreatic fistula, right? Amylase is high. Do you know of any classification system which will help you determine that this fistula will close spontaneously or you need intervention? Do you know of any classification?
Sir, MRCP guided DIDGO classification. No, that is clinical classification.
It's called Nielsen's. Have you heard of Nielsen's classification?
Yes, sir. Nielsen classification.
So in that case, which ones do you think would spontaneously close and which ones will not?
Sir, the first one in which the pancreatic duct is normal would close itself. In the second one where there is a stricture present, and in the third one where there is a disrupted pancreatic duct. In those cases, it would not.
Basically, you have to see whether the duct is patent or not, main duct.
Yes,
if the main duct is patent, if it's from the side ducts, it will close, number one.
Yes, sir.
Number two, you have to see that there's no chronic pancreatitis with the stricturing of the main pancreatic duct. If that is the case, it will never close. You'll have to go in for some surgical intervention. So, right, so that is a thing. Right?
For that to find out what's the investigation of choice.
Yes.
MRCP, sir.
Yeah, this is what I said initially. To find the relation between the duct and the cyst, it's better to go for MR than CT scan. CT scan will show the other anatomical details except the relation between the duct and the cyst, which is better picked up either a stricture or the disrupted duct syndrome, disconnected duct syndrome, or any upstream, chronic pancreatitis changes in the duct, including the side branches. So ductal anatomy is better with MR.
I could also go in for an ERCP and do a, right there also do a, say there's a stricture, you put a stent, you can put a stent also. Yes. So ERCP will also give you the same thing, but of course, as he rightly said, for diagnosis only is MRCP. If you want planning a therapeutic thing, then maybe yes, ERCP also will give you the same information.
Yes, sir.
When you do an external drainage, suppose you go in with a plan of an internal drainage. For some reasons, you have to do an external drainage. What are those situations? Of course, internal drainage is always better, that we can avoid pancreatic fistula, but indications for external drainage.
Sir, extensive necrosis. And if the infection is present, I would better want to drain it externally, sir.
Yeah, extensive necrosis is not an indication. A second indication is if it's a
lavage,
frank pus. See, pancreatic abscess is not the term for in the revised Atlanta classification.
Yes,
it's only a WOPN. There will be necrosis. Yes, complete full of abscess. You can do an external drainage. Other area? Other situation.
Yes, sir.
If the wall thickness is not adequate for an internal drainage, so you go, you see a large infragastric cyst, you puncture it, and then you find that the cyst wall is not thick enough. Then also, because you cannot do a good anastomosis especially to the jejunum. In stomach retrogastric drainage, it's okay. The wall thickness, you can take a little chance, but in jejunum, the wall has to be quite thick, about at least 3-4 millimeter for the anastomosis to happen. So if you find the wall thickness is not adequate, and if it's a lot of pus with the infection, patient is not doing well, cannot withstand an anastomosis, then you can do an external drainage with the caveat that patient may, as sir put in, can go in for a pancreatic fistula.
Have you heard of a dual modality drainage? In continuation of the same what Dr. Senthil has asked, very infected cyst, and you put a percutaneous drain and drained it. What is a dual modality drainage?
Transgastric placement of the drain.
Very good.
Which I would like to.
You have to put two drains. One is a transgastric, another is a percutaneous. So you can lavage it through that drain. That's called a dual modality drainage, DMD.
Yes, sir.
Those are reserved for.
You have done a cystogastrostomy, and with the idea that the contents in the cyst will drain into the stomach. After sometimes, if you eat, will the content will go to the cyst?
No, sir.
Why?
Sir, because of the peristaltic action of the stomach wall, the stomach contents are better propelled forward.
What is that
not
effect
into
called?
the cyst itself.
What is that effect is called?
Sir, sump syndrome.
No, sump syndrome is opposite.
If it is opposite of that, yes, sir.
It's a Venturian effect. When the via naturalis is patent, the side hole will heal automatically. Suppose you said the profuse bleeding. You have done an anastomosis, you are getting extensive bleeding, the vessels are not controllable. How do you manage that?
That's important.
Sir, I would like to go for endoscopic examination and see whether the bleeding vessels are from the anastomotic site. And I would like to go for stapler application or the suturing for those bleeding vessels, sir.
Any other cause of bleeding? Apart from what sutures do you use? Sorry, what sutures do you use for a cystogastrostomy? Sorry.
Absorbable sutures.
Open cystogastrostomy, what sutures do you use?
Absorbable sutures, sir.
2-0 absorbable sutures. Would you place them continuously or do you place them interrupted?
Interrupted, sir.
Why interrupted? Why not continuous?
Sir, it would cut through if I place it continuously over the whole cystic wall.
Yes, it can not only cut through, it can give way and make it loose. The sutures make it loose and can bleed. Right.
Yes, sir.
And what are the other causes of bleeding? One is from the maybe anastomosis, there's bleeding. Any other cause of bleeding post-operative?
Sir, surrounding varices may be present, which may be encroached into the, I've taken into the suture.
Your patient has chronic alcoholic, right? So you have to see in the CT also, we forgot to see the portal vein, splenic vein, everything, all that vein, right? So it could bleed from varices, all right. Okay, what else?
Yes, sir. Patient, I would check for the coagulopathy if present.
Coagulopathy, that's a normal thing. Or anything else
Okay.
specific in this pseudopancreatic cyst?
There may be rupture of the nearby aneurysm into the
Yes,
cyst.
pseudoaneurysm can form, which can rupture,
Yes,
right?
sir.
What is the artery commonly which happen when it happens?
Splenic artery aneurysm, sir.
Most commonly splenic artery. It can happen in other also, gastroduodenal, splenic,
Gastroduodenal.
arteries, but the splenic is the commonest.
What's
Right.
treatment for a pseudo, aneurysm?
Sir, I would like to go for angioembolization first, and if not treated, then surgical.
You don't have an option?
Then I would like, then straight away surgical if no availability of angioembolization, sir.
So what do you do in surgery?
Can you localize? It is not possible.
You won't be able to localize. What will you do then? What can you do? It's a very difficult. Nobody. I would not like to do it. But what would you do if suppose you are faced with that?
Sir, I would like to, if not localized.
See, it's a pseudoaneurysm. You said.
No, sir, I don't know.
It's a very impossible situation. You have to get control of the vessel both proximally and distally. Whichever, splenic artery, proximal and distal control, and you can clap. But nobody would like to be in that situation, any of us. So angioembolization probably is the best way to do it.
Yes, sir.
And then see the other famous, general question is, rightly said, the cyst, the food doesn't pass into the cyst cavity. One you said peristalsis. The other reason is intragastric pressure is always lower than the intracystic pressure.
Yes, sir.
So that because of the pressure difference, food doesn't pass into the cyst. Generally, the reverse happens. And how long will the cyst generally takes to completely get it obliterated? So you do an endoscopy after a cystogastrostomy. How long generally it takes to completely obliterate the cavity or the cyst?
6 to 8 weeks, sir.
Generally, even in 4 to 6 weeks, you see the cyst completely getting collapsed.
Yes, sir.
Right. I think we've covered a lot.
Yes, well done. Done well.
Yes, we've done very well. Densi, yes, excellent.
Thank you, sir.
Thank you, Densi. Thank you, faculty.
Which college are you
from?
I think you've been.
I'm from BJ Medical College, sir.
And your boss is Pankaj Modi?
My PG teacher is Nitin Parmar, sir.
In the same institution, sir, other unit.
Yes, sir.
So, Densi, do you have any questions to be clarified? Now we have the national teachers available for you to address your questions. You have been asked on various spectrum. Do you want any clarifications or any doubts to be clarified? I think you have the privilege to get clarified now.
You have a chance to take revenge. Ask as much as you want.
Thank you, sir, for the chance. No specific questions, sir. Thank you.
Thank you.
This is a time that you can clarify some. If you have anything, you can know. There may be a lot of questions, a lot of clarity, some gray areas, especially, which you want to clarify. We will be happy to answer.
Sir, I think we have a few questions in the chat box.
So what is the classification, sir? Pankaj Modi, sir.
That's Nielsen's classification. N-E-A-L-S-O-N.
Good evening, sir.
Nielsen's classification for pancreatic fistula. And the other question, sir, you were discussing about what happens to the drained cyst. One of the candidates has asked, sir, how is the intracystic pressure more than the intragastric pressure?
Okay.
Yes, sir.
I'll answer that. This is the pseudocyst is basically the fluid collection surrounded by fibrous capsule. That's the reaction of the surrounding area. It doesn't have a true lining. It's basically a fibrous capsule. So that always try to shrink. Any fibrosis tries to shrink. So the moment you puncture, it's like puncturing a balloon. So the cyst pressure is always more because the cyst wall tries to compress and then.
Sorry.
So I was muted. So because of the fibrous capsule, fibrous covering layer, it's not a true lining, epithelial lining. So the pressure, it tries to compress. Imagine you puncture a balloon and then it tries to compress so that it gets deflated. Likewise, when you try to compress or try to make an internal drainage, it tries to collapse. So because it tries to always contract, the pressure inside the cyst is more than the intragastric pressure. So that's the reason food doesn't pass into the cyst. Rather, the content of the cyst, even it's a necrosome. So that's why we don't do a very diligent necrosectomy. Only loose necrosed material are allowed to remove because of the two reasons. One, it can get stuck to the underlying vessel. Thereby, you can create a major bleeding, like opening up of the splenic vein or the splenic artery. And the second thing is, it's not needed. Obviously, it's going to come into the cavity or into the stomach over a period of time when there is a clear demarcation. So for these reasons, always the cystic pressure, intracystic pressure is high than gastric or the jejunal pressure. So you can rest assured that it collapses within 4 to 6 weeks because of the tendency of the wall, nothing to do with the content. Tendency of the wall, it's a fibrotic wall, it contracts and then it gets obliterated. I hope that answered the question.
Thank you, sir. Thank you. Thank you, faculty. Now we move on to the next case. Senthilnathan sir, I'm not sure, but I would still request you to stay back for the thyroid case for discussion. Maybe pancreas and thyroid are friends. Otherwise, let us have Professor M.J. Paul, the Professor of Surgery from CMC Vellore. Sir has been waiting for some time. Sorry for making you wait, sir. Now we will have the candidate from Dr. Rajgopal sir's unit, Dr. Karan Agarwal, to start his presentation. Senthil sir, like if you feel very odd man out, please feel free to take leave, sir.
I will silently watch probably after
absolutely
the video.
Most welcome to stay back, sir.
Sure.
Hello, good evening. Can you hear me?
Yes, sir. Yes.
Welcome,
Good evening,
Dr.
sir.
Paul.
Good evening,
Good
Paul,
evening.
sir.
Hello, Kanavel. Hello.
Good evening.
Hello, Dr. Shanoy. Yeah.
Yes, good evening.
Can we have the presentation up, sir? Paul, sir, Professor Paul, sir. Can we have
Yeah,
it?
please. Yeah, please.
Dr. Karan, please introduce yourself and start your presentation.
Good evening, everyone. I am Dr. Karan. My guide is Dr. Rajgopal Shinoy from KMC Manipal. I'll be presenting a case of a 45-year-old male hailing from Shimoga, teacher by occupation, with the chief complaint of swelling in front of neck since past 10 months. History of presenting illness. Patient was apparently asymptomatic 10 months back when he noticed a swelling in front of his neck after his family members mentioned it to him. He described this as a painless swelling and has noticed hardly any change in size since then. Subsequently, he underwent evaluation for the swelling at an outside hospital and an aspiration testing was done, following which he was advised surgery and was referred for further management. No history of recent or rapid increase in size of swelling or any episodes of associated pain. No dyspnea or discomfort while swallowing or hoarseness of voice. No history of loss of weight, anxiety, tremor, sleep disturbance, increased bowel movements, increased sweating or heat intolerance. No history of palpitations or exertional chest pain or dyspnea. No history of weight gain, constipation, lethargy or cold intolerance. No history of noticing any other swelling in the neck. Past history, no previous history of diabetes mellitus, hypertension, ischemic heart disease, bronchial asthma or pulmonary tuberculosis. No history of prior admissions or drug intake even after the visit to the doctor 8 months back. No history of radiation therapy received in the past. Personal history, patient consumes a mixed diet. There's no change in sleep habits or appetite. Bowel and bladder habits are normal. There are no addictions. Family history, no history of goiter, malignancy, or any hereditary disorders in the family. Treatment history, patient gives a history of undergoing an ultrasound scan of the neck and an aspiration testing of the swelling, which was sent for analysis. Patient was advised surgery thereafter. Summary, 45-year-old male presented with history of a painless swelling in front of neck since 10 months, which has not progressed in size. He has no associated symptoms of hyper or hypothyroidism. Clinically, no history suggestive of malignancy. He was advised for surgery after evaluation at outside hospital.
Karan,
Yes, sir.
just go back to your first slide, please.
Yes, sir.
Right, the next one, please.
Yes.
Use subsequent. Okay, just flip through it fast. Yeah. Okay. Sorry. You took drug history. Which drug did you ask for specifically, and how?
So for drug history, we asked following his visit to the hospital whether any medications were started. If the patient was hypothyroidic or hyperthyroidism was there, features were there at that time for which treatment might have been given.
Any other drugs which can cause swelling in the thyroid?
Yes, sir. If a PAS was given to the patient, or
you took history of for the sleep and what was the other one? Just go back. Anxiety and sleep. Just go back. Sleep disturbance.
Yes.
Why did you take history of that? How has sleep disturbance got to do with, or anxiety got to do with?
So the primary thyrotoxicosis in the CNS symptoms, patient presents with anxiety and sleep disturbances.
What kind of sleep? Do they present with sleep disturbance? Is there any sleep disturbance in thyrotoxicosis?
In primary thyrotoxicosis,
is there sleep disturbance or not?
Yes,
so
sir.
I'm not coming across it. He may be anxious, but there's not sleep disturbance. This would, if he has any mental issues, he'd be taking lithium.
Yes, that will cause the hypothyroidism.
And that can cause. So the sleep disturbance is not for thyrotoxicosis, but for any psychiatric disorders where lithium would have been prescribed.
Yes.
Right.
Okay, I think that's a good history, Karan. At your level, you have covered all the issues. So the assessment of a thyroid nodule, I think, have you, or a neck, you only presented this as a neck swelling. So how will you know that this is a thyroid nodule on your history? Is there anything to go by in the history that this could be thyroid? It's anterior, front of the neck, isn't it?
Yes, sir. Sir, it is painless and slowly progressing, sir.
Even the posterior triangle is also front of the neck, even the lateral triangles. I mean, anything specifically you want to say on the thyroid?
On history, sir. Hello.
Yeah.
History wise, sir, the points favoring is it is a slow growing swelling, sir, and painless, sir.
Yeah.
If it was and patient has no other symptoms, sir.
So actually, it's okay. It doesn't matter. Not a very important question. It's just that swelling in the front of the neck, which the patient reports to you. I mean, we haven't come to clinical examination yet. The only thing the patient can probably tell you that he noticed that it moves when he swallows, isn't it?
Deglutition, yes, sir.
Otherwise, it's very, in the absence of hyper or hypofunction, it is not possible on the history to actually make out, except for this one thing. Yeah. And it's interesting how people actually find, as you said, somebody in the family noticed, no? Many of them say,
yes, sir.
When is the usual scenario that they notice the swelling? Often when the patient is eating in front, when they sit together and eat, when he swallows, it will move. So that's when it becomes prominent, and a family member sitting opposite will see it. There are various ways. Historically, it can happen. We have had patients sometimes because of the contrasting light. One patient told me they came on the wedding scene and they were all standing, with the bride and groom, and because the video light was shining the light from the side, they could actually make out on the video when they watched that there was a swelling there, which they didn't know earlier. One doctor came to me saying that, one of my friends was looking at my driving license, and the driving license photograph, you could see there was a little nodule, which she had not noticed herself. So there are various ways where interesting how these nodules are picked up. But as you said, most often it is usually asymptomatic and it goes on for quite some time and becomes large, and you'll be wondering how are they sitting on this nodule. Why is it that it does not call attention to the patient usually?
Sir, painless.
Maybe even when it's a size of, it will be 5 centimeters, and the patient will say, I don't feel anything. Why is it that they don't feel, even if the trachea sometimes is moved to the side? Because the slow growing swelling, slowly the tissues adjust, so they don't actually feel anything unless it's fast growing or inflammatory or infiltrative. Often that is the problem, that they don't pick it up. Okay, so just a few points in history. Otherwise, I think you've covered very well.
I just want to ask 1 or 2 questions for postgraduates. What history is suggestive of malignancy, which you can take? You have written no history, but can you repeat a few histories?
Yes, sir. Sir, any change in voice, any dyspnea, and any dysphagia.
Just 1 second, Karan. What sir has asked, you must go in a certain order. So the way you presented, what is the first thing you said?
A fast growing, it will be a fast growing.
First thing presented is the age of the patient. So
yes,
you must in the same order. So does age is a historical risk?
Yes, sir. So 45 patient is risk for papillary carcinoma, sir, of thyroid.
Male is a risk?
Male is a risk factor, sir. Male patients are 4 times higher risk females are at higher risk for papillary carcinoma than males, sir. But hello.
No, incidence of thyroid nodules are comparatively definitely more common in females. I think there is a doubt about that. Correct?
Yes, sir. Yes, sir. So, but if a nodule is present in males, it has, if it is in a male, it has 4 times higher risk as compared to a female.
That rule of solitary solid.
Yes, sir. Yes, sir. Yes, sir.
No, it's not 4 times. It's just a slightly higher risk.
Yes.
In a male, a nodule is more likely to be malignant.
Yes.
You're right.
Yes.
Why is
Yes,
that? Why women have more cancers in the thyroid, but they are less at risk if they have an? Or why is that?
Incidence is more.
How do you explain that?
Sir, incidence of nodules are more in females, sir. But the incidence of nodules being malignant are more in males, sir.
That's right. So the benign nodules outnumber the malignant nodules in women. So even though the overall number is more, the percentage is less. So that's the risk factor, right? Correct.
My point which I wanted to ask.
What is the next one?
Change in the voice versus, can you explain what is change in the voice? What is the hoarseness of the voice? And what does patient tell you? How we can make out?
Sir, they will complain of voice becoming high pitch is lost. Sir, deepening of voice.
So the best is to say yes, alteration in the voice, some kind of a hoarseness of the voice.
Yes.
What is the commonest cause of hoarseness of voice in a patient with the thyroid?
Yes.
Recurrent laryngeal nerve involvement, sir.
No.
Yes.
Other than malignancy, you can have a hypothyroidism when the patient go for hypothyroidism.
Edema of the vocal cord, sir. Edema of the vocal.
Voice change is more common. Don't think voice change is just an indication for malignancy only.
Yes.
So we are talking in this patient, when you are asked, that should be your answers in the sense. I want to rule out indirectly, especially anaplastic and all can be very so rapidly growing and with the change in the voice. Change in the voice can present. That is one you have written there. What other history you have asked? Suggestive of malignancy. One is rapid growth. Yes.
Painless swelling, sir. In case of
painless swelling does not mean it is malignancy. Okay.
Yes. Then it is non-progressive. No features. No dyspnea. No dysphagia.
No. 1 minute. Dyspnea, dysphagia can be seen very well in benign condition. Okay. To wind up, I want to say that patient has not noticed any other swellings in the lower neck. Better use the word lower neck, not submental, etc. You want to rule out a papillary carcinoma or any other swellings elsewhere. Where is elsewhere?
Sir, lymph nodal swelling, sir. In the
lymph node mentioned, no.
And otherwise, sir, bony swelling, sir.
Some other time patient will come and tell you, sir, something is here in the bone.
Follicular. Yes.
So in other words, this is how that you take the history of local history. Local history is rapid growth, and then altered voice or change in the voice, and then don't say dysphagia. Dysphagia can due to very many causes. Then next swelling. Yes, sir. Please take over, sir.
Why thyroid produce dysphagia? Is it directly related to the esophagus?
No, sir. It is false dysphagia because of swallowing. The gland itself is enlarged, so swallowing is difficult, sir. Usually, the esophagus is muscular tube, so it doesn't cause compression.
It has any direct relation to the esophagus, thyroid. What is behind thyroid?
Sir?
Posterior to thyroid gland is trachea.
Trachea, yes, sir.
Posterior to trachea is esophagus. And how the esophagus is compressed by the thyroid?
I say it is not compressed by the thyroid, sir, directly, sir.
It's compressed by the trachea then.
Sir, the posterior lobe of the thyroid.
When you do not know the answer, say you don't know. He will tell you the answer. Okay, Karan?
Sometimes the thyroid, it is not from the anterior posterior compression. Sometimes you can get a lateral to medial compression. You can have.
Yes.
Go ahead, Karan. Change the slide. Yes.
General physical examination. Patient was examined after obtaining consent in the privacy of a well-lit room. He was conscious or oriented to time, place, and person at the time of examination. Well built and nourished. BMI of 26 was there. Examination of vitals, pulse rate 84 beats per minute, right radial artery, supine position, normal volume and character, regular rhythm. Blood pressure was 130 by 80 millimeters of mercury, right arm supine position. Respiratory rate was 12 breaths per minute. Patient was well hydrated. There was no pallor, icterus, cyanosis, generalized lymphadenopathy or pedal edema during examination. Examination of neck. A patient was examining after obtaining consent in the privacy of a well-lit room, neck well exposed to nipple. Inspection. A single swelling approximately 4 into 4 centimeter was noticed in front of the neck in midline, extending approximately 3 centimeters from the suprasternal notch and about 12 centimeters below the mentum. Swelling appears to have a smooth surface with distinct borders and becomes more prominent on neck extension. The swelling moves with deglutition and does not move with protrusion of tongue. The swing over the swelling appears normal. There are no scars or sinuses noted. There are no visible dilated veins or pulsations noted. There are no other swellings were noted in the neck. Palpation, no rise in temperature or tenderness noted. Inspectory findings were confirmed. A 4 into 4 centimeter single spherical swelling in front of the neck, firm in consistency, with smooth surface and discrete borders is noted, which moves with deglutition. The rest of the thyroid gland was not palpable. No other swellings palpable in the neck. No palpable cervical lymphadenopathy noted. Trachea is central in position. Percussion over the sternum was normal. No bruit were heard on auscultation. No signs of thyrotoxicosis. No eye signs. No tremors. No tongue fasciculations noted. Systemic examination, respiratory system, normal vesicular breath sounds were noted. No added sound. CVS S1, S2 were heard, no murmurs, no abnormalities detected. CNS, no focal neurological deficits were there. Skull and spine, skeletal system examination was normal. Per abdomen, no masses or organomegaly. This was the swelling. Diagnosis, solitary nodule of thyroid, I would like to keep as my diagnosis, sir.
Okay, the first point. What is a complete surgical diagnosis? I think that is the most important. There are two components to diagnose. It must be anatomical, pathological, and in terms of thyroid, we even give a functional diagnosis, isn't it?
Benign.
So you have only told us the anatomical. That means where is the lump arising from? You are saying it's a thyroid. You haven't even told us which lobe.
Which lobe of the thyroid has to be said?
So it's an incomplete anatomical. You understand? You have three components for diagnosis. You have given us only half of one component. So that is in fact a common mistake that is made, and it's sort of important to give a very thorough clinical diagnosis at the end of it. Okay, then otherwise we will be led off on a certain track. So what will you say? Solitary nodule arising in the
isthmus of the thyroid.
Isthmus of thyroid, and likely to be what pathology?
Benign pathology, sir, and most likely euthyroidic patient.
Yeah, benign means what? What is the benign pathology? What are the benign pathologies you know?
It could be a colloid goiter, sir.
Okay, so that's a hypoplastic nodule. It could be.
Yes.
What are the other benign?
It could be a adenoma, sir.
Could be adenoma. Very good. Any other benign pathology?
It could be.
Can it be a cyst?
Yes, sir. It could be a benign cyst, sir. Yes.
It's firm on palpation. Can you elicit cystic nature in a thyroid swelling?
No, sir. They have fluctuation present, sir, but they are firm on palpation, sir. Cystic swellings of the thyroid, sir.
So you can get fluctuation in this? Okay,
yes,
why
sir.
is it difficult? Even if it's cystic, it is usually not possible unless the patient is very thin-necked and it's a very anterior projecting swelling. Then rare situations you can elicit. Very thin lady who's emaciated, because it is in the deep plane, no, posterior to the muscle. That's why all deep swellings very difficult to elicit cystic nature unless they're very large and soft. So your other component is what is the third component? You have to tell the function. Euthyroid. Very good. So what is your full diagnosis now? Of these benign ones, which one are you saying it is likely to be?
Benign, most likely it is a colloid nodule, sir. So solitary colloid nodule of the isthmus, euthyroidic status.
Okay. Now, sir, other examiners can you comment on the diagnosis?
I think he knows the FNSC diagnosis. So don't try to say colloid goiter for for this. If you have told a dominant nodule, that would have been enough. I know.
Yes,
definitely left lobe is not enlarged, right lobe is not enlarged. In almost 40 to 50% solitary nodule turns out to be what?
Dominant nodules.
Then why didn't you give a diagnosis when this question was asked? So what I'm trying to tell is, you instead of trying to colloid, I think is not a clinically at this stage we can't accept it.
Yes.
Even if you have a hyperplastic nodule, I think it is okay. But even then, it's a pathology. Hyperplastic nodule is a FNSC diagnosis.
Yes.
So if you would have easily, if the question was asked benign, you could have even mentioned cyst, correct? Then a dominant nodule is fine. Not which is the common site of a nodule in this area. Is it in the center like this, or?
Sir, it's at the junction of the isthmus and one of the lobes, sir.
Usually that junction, isthmolobar area.
Yes, sir.
So I prefer to give as a dominant nodule rather than you are taking colloid nodule. Okay.
Yes.
That's what what about Jailal, sir? What do you think?
Yes. That's right. You are also putting you're not mentioning about thyroid region. I mean, you are just always you are talking about the front of the neck. It is better that it's a vast area. As a postgraduate, you can
just go back to the first slide, that inspection. What sir is asking. Show what exactly you have written. So again, front of the neck is the history. So you should not use that in examination terms. Examination terms should be in terms of anatomical detail, no?
Yes.
So what is that area called, which you're calling front of the neck in terms of triangles? So?
It's a muscular triangle, sir.
Muscular triangle, which is a subcomponent of the anterior triangle.
You could have happily told us in the region of isthmus of the thyroid. Would have been happy also. Obviously, expect a question: what is the relationship of the nodule to the isthmus? Dr. Ishwar Osmani has joined us. He's a professor from Kim Subli. If you have any question, you can ask, sir. No problem.
Sir, there's not a question, sir. It's just some clarification.
Yes.
When you have made it clinically, it is a dominant nodule. By definition, it is the nodule felt in the lobe of the thyroid. The remaining part of the gland clinically is not palpable. on ultrasound, there could have been some few nodules. Then only we call it as a dominant nodule. Am I right, sir?
Yes, sir.
Sir, here we are not using the word ultrasound, no, sir. Right now we are in the clinical examination.
When you call it as a dominant nodule, means there has to be some more few nodules which were there in the thyroid gland, which have been not palpable clinically. That's what exactly
the
meaning of
palpation slide.
Yes, sir.
Yeah, palpation.
There
Yeah,
were
so there you have
no
said
other.
single spherical swelling, which moves. The rest of the gland is not palpable. So I agree with sir. In this situation where you're saying there's only a single discrete swelling and the rest of the gland is not palpable, we do call it a solitary nodule. Clinically, it's a solitary nodule. And I think that what sir is saying is that if you go ahead and do an ultrasound or you remove the gland and do pathology, in 40 to 50%, you are likely to find
multiple nodules were there, which would have been not palpable clinically. Then we call it as a dominant nodule.
Yeah, after the ultrasound or the pathology. But here, clinically, you are saying the rest of the gland is not palpable. That is the definition of solitary nodule. Is that okay, sir? Yeah, I think that's correct.
What is the relation of a thyroid swelling and the sternocleidomastoid?
It is medial to the sternocleidomastoid, sir.
There's a big thyroid swelling is there. What is the relation to the sternocleidomastoid?
Sir, behind and medial to it, sir.
Can it go in front of the sternocleidomastoid, the thyroid swelling?
No, sir.
Yeah. So it can never go in front of the sternum. It will be, whatever the size of thyroid swelling may be there, it will be always deeper to the sternocleidomastoid. Did you palpate the carotid pulsations here?
Yes, sir. Carotids were palpable, sir, bilateral.
Which carotid did you feel?
Common carotid, sir.
What other carotids you can feel in the neck?
Common carotid only, sir.
And what about the external and the internal carotid?
Sir. No, sir. Only the common carotid at the.
So where can you feel the internal carotid? If you have to feel the internal carotid, can you feel it in the neck or not?
Don't know, sir. No, sir.
Feel it in the tonsillar fossa. Okay, so you have to put your finger inside and then you can feel it in the tonsillar fossa. External carotid can be felt at the almost near the mastoid. If you feel near the mastoid, then you can have some feeling of the external carotid. But internal carotid is always felt inside the oral cavity. Okay.
Yes. Yes.
Can you tell on inspection that the trachea shifted or not?
Yes, sir. Trachea central, sir, in position.
No, but if the trachea shifted, can you tell it on inspection?
Yes, sir. Yes, sir. It is seen on inspection, sir.
How?
The prominence of the sternocleidomastoid will be there, sir.
So why is it that the thyroid always enlarges deep? It's better when you say, don't say front and back. Now, when you're talking examination, always anatomical terms. So it will be superficial and deep. So when a thyroid enlarges, it enlarges in a plane deep to the sternomastoid. So it pushes it anteriorly. Why does that happen? What are the fascial layers of the neck? Can you explain why that happens based on the fascia?
Sir, it is enclosed in the pretracheal fascia, sir.
The thyroid, yes.
Yes, sir. So
that fascia comes from where?
From the it comes from the hyoid bone, sir. It splits.
It belongs to which area? Which it's a prevertebral fascia or what fascia?
The posterior layer is a part of the prevertebral fascia, sir. Of that.
Okay, what are the three fascial layers? Just say from superficial to deep.
The first one is deep the platysma.
No, deep fascial layers of the neck. In anatomy, they would have drilled it into your head, no?
Yes, sir.
What is the main fascia of the neck?
It's
called what covers the muscle? See, investing fascia.
Investing.
Yeah, so the investing.
Cervical.
See, these are the deep cervical facial layers. You have to know this very clearly, Karan.
Yes,
yeah.
Sir. Yes. Sir.
So you got skin superficial fascia with platysma. Then beyond that is all deep cervical fascia. The first outermost layer is the investing. It's called investing because it clothes or encloses the muscles, the strap muscle and the sternomastoid. So they all come in one plane, strap muscle, sternomastoid. Please go and refer your anatomy book. You must be very clear with this. Then deep to that is the pretracheal, very good, which encloses the thyroid in the midline and the forms the carotid sheath laterally. So they are all in the same plane. And deep to that is the prevertebral, which covers the prevertebral muscles and the vertebral column. Yeah. So when the thyroid enlarges, it expands the pretracheal fascia, which is loose areolar tissue, and pushes the carotid laterally and expanding in a plane deep to the investing fascia, which is enclosing all the muscles. So that's very typical. When a large goiter goes to one side laterally, you can see the sternomastoid is stretched over it, isn't it? That's a very classic sign. And then additionally, if they are moving with deglutition, then you know for sure that you're dealing with the thyroid, isn't it? The other question is, what is the differential diagnosis of swelling that is moving? You're saying now this is moving with deglutition. What else could it be if it is not a thyroid?
Sir, a subhyoid bursitis could be there. Thyroglossal cyst could be there.
Don't say subhyoid bursitis in this
the lower end.
Those are high. Those are high up in the neck. Thyroglossus cysts. Now in this area, what is there?
Pretracheal lymph nodes could be there, sir. Pretracheal, paratracheal.
Pre or paratracheal. Yeah, pretracheal are the one that usually can be seen or palpated clinically. Very good. Anything else? What are the other structures there? So rarely you can get a
thyroid adenoma. Yes, sir.
Parathyroid adenoma, 10% are palpable in our population. And extremely rarely from the trachea, can you get a swelling?
Laryngocele.
Laryngocele, I don't know if anyone has seen it clinically. Now it's very, very unusual. It's just a historical thing. But primary tracheal tumors, very rarely. We have actually gone in on a goiter and found behind that a primary tracheal tumor. So you must remember just the anatomical structures and what could arise from them. These are the ones that move. But 99% are thyroid. Yeah, that's why.
And in this location, if the easy case for you, not much of findings. They may ask if the swelling does not move with the deglutition, what is your diagnosis? You look at that suprasternal space, very, very close to that lower margin there, correct? Show the figure one, show the picture one. Yeah. If it is that does not move with the deglutition, what is your diagnosis?
Very good question.
Yes.
Googly question.
Because what happens is, sir, these people will go with by heart like this, and when in the exam there may be get a similar swelling, but not moving with the deglutition. They would have prepared for thyroid nodule. Yes, tell.
Thymoma could.
You can't. But is it common condition?
Common.
No, sir.
What is the age?
No. Younger, second decade usually.
So you consider now some swellings in that suprasternal space. Can be a lymph node, can be even fat also. Simple cysts, including a lipoma. So even a lymph node, cold abscess.
Cold abscess, yes.
One of the sites of a cold abscess, suprasternal space here. Okay, suprasternal space.
Coming there.
Dermoid.
Midline swelling, dermoid. So all these things are described. You should be ready for that. All right, sir.
Still, it is a thyroid. Yes, it is not moving with deglutition. Why you will think that? Can it be a thyroid still not moving?
Yes, sir. In case of malignancy, if it is infiltrating the trachea,
what malignancy?
Anaplastic carcinoma usually, sir.
What we do?
And also male thyroid, and if the stronger neck muscle, it can become slowly retrosternal. Okay, because of the stronger neck muscles. That's what makes it sometimes slowly retrosternal in a longer duration. Yes.
So the other question is, why does it move with deglutition?
Sir, the attachment to the Berry's ligament, sir, when the superior constrictor on deglutition, the superior constrictor contracts and it causes the Berry's ligament to be pulled up, which pulls the
How many Berry's ligament you have?
So one,
Haven't
sir.
you
One Berry ligament.
seen a thyroidectomy?
Yes, sir. Yes, sir.
This is
So
where
it's attached only at the Berry's
that
ligament,
mistake.
and the rest
Is
is hanging free.
Pretracheal fascia
Yeah. So
moves
the
with.
answer how you the thyroid gland is enclosed in pretracheal fascia, which is condensed posteriorly, and it's attached actually oblique line of thyroid, cricoid, and trachea. Okay. And the
Yes.
strongest point of attachment is the Berry's ligament. The whole posterior aspect is actually attached. That's what you have to remember. When you see a next thyroidectomy, you please observe how it is closely bound to the whole laryngotracheal apparatus. Okay. So why does this thing move up anyway with deglutition? Why does your laryngotracheal structure move up and pull the thyroid with it, which is attached?
The hyoid bone moves on deglutation, sir.
No, it is only the hyoid. No, correct.
No, the hyoid bone doesn't move. It is fixed. So what is the
superior constrict?
Superior.
No, why does this thing have to move up at all? What is the purpose of that movement? You must be clear about this. It's a very basic question. So you're saying the thyroid moves because it's attached to the laryngotracheal apparatus. Why does the laryngotracheal apparatus move and pull the thyroid? It is to close the glottic opening during the act of swallowing, to prevent aspiration. That's all there is to it. Okay. It's very interesting in comparative anatomy that only in humans this happens. In all animals, the food does not cross the glottis, it goes by the side. Because the larynx developed specially for voice in humans, it actually moved downwards and became enlarged for the purpose of voice. So when you look at comparative anatomy, this is a unique thing. No animal aspirates except humans because of this. So that's an interesting point. You must know that. What is the, sorry, anyone else would like to ask a question there?
You said there is only one Berry's ligament.
Yes, so both sides.
Both sides, okay.
I think sir wants to impress upon the when you are doing a total thyroidectomy, the last part, when you are trying to mobilize that, when you are identifying the recurrent laryngeal, as you are tracing it up, there are some fibrous bands like thicker area. That is what is Berry's ligament. It is like you have to really carefully to see it rather than it's and feel that. Otherwise, you tend to miss it as a fibrous band. That's all.
What is tubercle of Zuckerkandl? Do you know?
Yes, that is the area where the thyroid gland is close to the recurrent laryngeal nerve, sir. So that is the area where usually a piece of the thyroid is left behind, sir, which can cause recurrence. It is bounded by the internal carotid artery, the superior thyroid artery, and
Sir has asked a very simple question. What is the organ of Zuckerkandl? Why do you go for a triangles and all?
It's just a posterior prolongation of thyroid tissue at the posterior aspect, and it's closely related to the Berry ligament. What is the surgical importance is that?
Recurrent laryngeal nerve is close to.
It passes posteromedially usually, and very rarely on the lateral aspect of the ligament of the tubercle. So it's a good marker for your nerve. And if it's enlarged, then it will cover the nerve, and you have to carefully look for it and dissect. And the superior parathyroid is also usually on its superior aspect. So these two important structures are related surgically. Okay. So shall we move to the investigations? You have some investigation.
Sir, the ultrasound of the neck was done, sir. It showed the thyroid gland is enlarged and multiple heterogeneous, predominantly hyperechoic solid cystic nodules were there. The largest was 2.6 into 1.78 centimeters in the left lobe of thyroid. Most of the nodules had hypoechoic halos in the periphery, and bilateral level 1B, 2A, and 2B lymph nodes were there, but with maintained fatty hilums. It showed a thyroid 3 nodule features suggestive of multinodular goiter with thyroid's 3 category.
I think this is what Dr. Ishwar Hosmani was talking about, that you have feeling one nodule and ultrasound says few nodules like this. So then that becomes the dominant nodule of multinodular goiter. That's what.
Goiter. Yes, sir.
But sir, now in the clinics, when the question of DD comes for a single nodule, differential diagnosis, when we teach them, first thing we tell is more than majority are a part of multinodular goiter. That's a dominant. Then he was asked, he said colloid goiter, but colloid we don't expect to say as a,
solitary.
Yeah, so that's one thing. A cyst was asked to him that tensely cyst feels firm or even hard. Dr. Paul, one question just for our purpose. Even though tensely cystic things will feel firm or even hard, can they clinically say Paget's test? Some of them we put a pressure with one finger, you get a yielding feeling. It like soft area. That
you can, but then it's only the muscle and fascia has to be so thin to allow that sensation. That's true. Right? Very thin patients, sometimes we can appreciate.
Then he gave the third diagnosis, adenoma. And then features of malignancy are not there in this. So so now
this fluctuation sign is classically described as thyroid paradox. Sir. Thyroid paradox is tensely cystic swellings felt as a firm. So that we clinically describe it as a thyroid paradox. Then this has to be illustrated Paget's test when the swelling is lesser than 2 centimeters, where you cannot put the 2 fingers. Exactly. If it is very small, only one index finger you can press at the center. That is the Paget's sign.
Yeah. So what happens is, Karan, even in a deep-seated breast lesions also, no, you may feel sometimes they are hard. It can be a tense cyst also. So something like that also happens in a sarcoma, especially in the thigh. Deep-seated abscess can mimic like a sarcoma, and you may think sarcoma, but hematoma especially. So because they are all deep locations. Yes. So please take over for the management.
So what is this thyroids? The expansion of that?
Yes, the thyroid's imaging report and data system, sir. So it has
reporting,
it has 5 categories in it, 1 to 5, sir. So it tells about the probability of malignancy, sir. Thyroids 1 has a 0.3% chance of malignancy. 2 has a 1.5% chance of malignancy. 3 has around 4.9% chance of malignancy. 4 has around 9% chance, and 5 has around 35% chance of malignancy, sir. They take into consideration 5 aspects seen in ultrasound reports, sir. So based on that, a total score is there, sir. So if the score is 0, it comes in thyroids 1, sir. If the score is 2, then it comes in thyroids 2. If the score is 3, it comes in thyroids 3. If the score is 4 to 6, it comes in thyroids 4. And if it is more than or equal to 7, it comes in thyroids 5, sir.
Okay, so what are those features actually that we're looking for? You must know what are the features of a malignant nodule on ultrasound?
Yes, sir. So one is shape, sir. So if it is taller than wider, then it is suggestive of malignancy. Then if composition wise, sir, if it is cystic, then it is non-malignant, sir. If it is solid, then it is malignant, and if it is mixed also, it is more suggestive of malignancy, sir. Then next is the echogenicity, sir. Anechoic is the least malignant. Hyperechoic is the most malignant, sir. Hypoechoic is considered benign, sir. Then we see the margins.
No, careful. Hyperechoic is benign. Hypoechoic is the one that is suspicious. Okay. Yeah. Why is that? Do you know what causes echogenicity in a nodule? It is usually the fibrous tissue, the degenerative tissue, the colloid content, and the vessel walls. Whereas a nodule that is very cellular, which is more likely to be neoplastic or malignant, cellular content has 60 to 70% water. So it looks very hypoechoic. So solid hypoechoic, taller than wide, irregular margin, increased intranodular vascularity with microcalcifications. These are all the features that raise risk. No one feature is good enough by itself. So that's why by ultrasound alone, we cannot be sure. So we'll move to the FNAC.
So the FNAC
so category 3 is likely to be probably benign. Yeah.
Yes, sir. So
Low risk of
FNAC,
malignancy.
FNAC was showing nodular colloid goiter, sir.
For the benefit of postgraduates, before Dr. Paul takes him for total thyroidectomy, Kiran, what are the investigations you have done other than ultrasound FNAC for very important for documentation here?
Thyroid function test and direct laryngoscopy, sir.
You should say video laryngoscopy. That
Video
is the preferred one. It's important to mention. Why video laryngoscopy?
Sir, patient might have a one side unilateral palsy of the vocal cord, sir.
Asymptomatic compensated due to what? Why is that?
Childhood viral exanthema could have caused that, sir.
So it's very important that to note that which side you are operating, right side, left side. Take precautions that you should mention. Understand?
Yes.
Even in here in the presentation, yes, ultrasound is extended arm, correct, but yeah, it's very important to not to forget the T3. At least if you are asked to do one test, you do T3 or T4 or TSH, which is better?
TSH, sir.
Yes.
Why
So
is
you
that?
said
Why is TSH alone enough? You explain.
Yes.
Screening for hypothyroidism, TSH is sufficient. That's what we want.
Yes, sir.
Why? Because it's most sensitive. So even when the thyroid hormone moves within the normal range, the TSH will respond higher and move out of the normal range. So you will pick up the dysfunction earlier by checking TSH alone. But if you have clinical hyper or hypothyroidism, then you do the all the tests. And anyway, now all the labs only do it as a package, I think. So you can't hardly. Only certain institutions you can get it separately. Yeah. So yes, sir very rightly said you should mention the function, and you must say that you performed the laryngoscopy before you go for the surgery. So how did you decide on this operation?
One more. What is the sir? One more investigation. And what is the role of CT in thyroid swellings?
Sir, in case of suspected malignancy, sir, to look for lymph nodal metastasis, and in case of retrosternal goiter.
Do a plain X-ray of the neck before you go for the surgery?
Yeah.
Yes, sir. Yes, sir. To check for tracheomalacia if it is there or not, and plus we will be putting.
Tracheomalacia cannot be seen by the CT.
Don't say tracheomalacia. Simple tracheal
deviation.
Deviation.
Tracheal deviation.
So how many views you will take? How many views you will take? One view or two views?
Two views, sir. AP and lateral, sir.
Why you do the AP and why you do the lateral?
Good question.
Why you do the AP view and why you do the lateral view?
Sir, AP will tell us any deviation is there, sir. Sideward lateral deviation is there or not.
How it is going to help you? Or your colleague? How it is going to help your colleague or you?
During the intubation, sir.
During the intubation?
So gross
don't know,
deviation.
You know, it will help you because you want, normally you will think it in the central part, but it's shifted to one side. So you have to definitely avoid the damage to the trachea. And from your anesthetist point of view, when he's putting the tube, he will always try to put it straight down. But if it is deviated, he has to manipulate that.
Yes.
Okay. And
So
then
he
you do
needs
the
to
lateral.
know it in 2 dimensions. There can be lateral deviation and anteroposterior deviation.
Yes.
So on only anterior view, you will not be able to see anteroposterior compression. So that's why they look at that. But one important thing is a chest X-ray is actually a very useful, apart from anesthetic requirement, for evaluation of thyroid, there are 3 points you can make out on just a plain chest X-ray. One is this tracheal deviation. You can get one lateral deviation. 2 is soft tissue extension retrosternally can be confirmed. You can actually see sometimes it's extension. Very rarely you may pick up a separate thyroid mass, which is a mediastinal mass. And third is metastatic lesions in the lung or bone of the bony rib cage. So that's chest X-ray is actually a very good investigation to go with the ultrasound when you're dealing with a thyroid.
So, Karan, once you finish that
for CT, sorry, sir, we'll just finish. Sir had asked the indication for CT. You must be very clear. What is the indication? One is retrosternal extension. You said. 2 is
if a malignancy is there, sir.
A large fixed mass. Yes, it's very. So you want to know the extent of infiltration. CT is best for that. And third is if there is suspicion of lung mets or there is extensive lymph nodal involvement in the neck, then you want to assess whether mediastinal involvement is also there. So these are the 3 reasons for doing a CT. Okay. Will you choose contrast or non-contrast CT?
So contrast to see the vascular anatomy as well, sir, whether it is a primary retrosternal or a secondary.
Okay, some people have concern regarding contrast. What is that because of?
Sir, iodine.
It may delay iodine therapy postoperatively. But
yes, sir.
I think most surgeons will agree that when you're suspecting local invasion, the contrast CT is very useful for surgical planning. So we generally, most surgeons will want it. I don't know, do the others agree? Dr. Shanoy, you were asking. Please go ahead.
Yes.
Then,
I just want to tell the postgraduate that again here, once the ultrasound X-ray, they ask you to say after thyroid exam ultrasound, then appearance is correct. But then you need to start with the blood test, chest X-ray, including X-ray neck AP lateral view. This is how you would start. Laryngoscopy, TSH, that has to come. Is it clear? Right, sir?
So one more additional, the use of CT in thyroid swelling, retrospectively it might help us to dissect the lateral compartment of the neck or not. Suppose the case has come as the FNS has come as a papillary carcinoma. If your image shows that there are no lateral lymphadenopathy, so you can restrict your neck dissection only to the central compartment. If your image shows that there is some nodes there in the lateral compartment which are suggestive of malignancy, and that is the indication for lateral compartment neck dissection. Okay, you have to technically go for a functional neck dissection. Otherwise, if it is papillary carcinoma, no image doesn't show the lateral neck nodes. Your dissection should be confined to the only central neck compartment. Probably CT may help you retrospectively if the FNS has come as a positive for a papillary carcinoma. To dissect or not to dissect of the lateral compartment has to be decided on the image studies only. Okay.
Yes.
But tell me, sir, I think as far as lateral compartment is concerned, sonography itself is enough, if I am right or wrong.
No, definitely, sir.
For sonography, which is not picking up the central nodes, that can be picked up by CT. But sonography, if it is normal for lateral compartment, I think that part should be okay. I'm not very sure of it, but this is what.
Yeah, I agree with that. The sonography is a better evaluator of lateral nodes than CT. The involvement of nodes is better assessed by ultrasound. And as you said, central and mediastinal is better seen on CT. So you need a combination of the two. In fact, you can even go one more step. Even if there is a suspicion of lateral neck nodes, ideally it should be cytologically or histopathologically proved for doing a neck dissection. That is the current recommendation, actually. Because many times, especially in our country, we get a lot of reactive lymphadenopathy for various reasons. So you may do a full neck dissection and find there is no tumor sitting there at all. So ideally, you must have some proof when it is not overtly malignant. Yes. Okay.
And here we can ask Karan one question. Yes. Sonographical findings suggestive of metastatic node rather than reactive node. How will you predict that? That also is.
The hilum is not maintained. The fatty hilum is not maintained.
How do you begin with? How do you begin with? Size, shape.
The size of this thing, the shape, it is In a benign, it is oval shape, sir, and it
Round
is
ones are
irregularly
usually positive.
positive, sir.
More than 1 centimeter?
More than 1 centimeter is suggestive of malignancy, sir. And a fatty hilum, if it is not maintained, that is suggestive of malignancy, sir.
Okay.
Cystic change and calcifications may be seen
Yes.
In lymph nodes. That is very specific for yes.
Will you do a radioisotope scan in this patient here?
Radioisotope. No, sir. At this point.
Usually, the radioisotope scan is not done as a preoperative.
Yes, sir.
Okay. Usually, it's for the post-operative purpose.
After the histopath report, sir, if it comes as a papillary carcinoma or follicular carcinoma, in this patient we will do, sir, because patient is high risk if it comes as a papillary or follicular carcinoma, sir, because male patient, higher age group.
Your answer should have been that.
Yeah, Doctor.
Sir, already patient. Yeah, sir. I just want to ask you that routinely it is not done. That sir asked you radioactive iodine in.
Yes, sir. In this patient we will do because yes, sir.
In this patient also you will not do. Don't worry. You have done already FNAC. They have done very clearly. So your answer, whatever you tell is right. That cold nodule and all, no, that those were done when the things were not available. We have the better facility now. The very limited indications preoperatively for I-131 or eye technician scan nowadays. So what your answer should be that this total thyroidectomy is done. If the report comes as papillary carcinoma, then you will do.
Yes.
Why you will do?
Sir, to look for any residual disease, sir, to look for any metastasis, and to look for any lymph nodal, sir.
Don't go in a jump now. Just say residual. You want to ablate that.
Yes.
No, that is the whole idea of doing it, not immediately after 4 weeks or so. I think.
Will you start thyroid supplement if it comes positive for malignancy?
No, sir. For 6 weeks till we do the radioiodine scan, we don't start the supplement.
And if it is benign, after how many days you should start thyroid supplement after total thyroidectomy?
If the final histopath report comes benign, sir, we can start immediately, sir.
We should start after 7 days. Half-life is around 7 days. We should start after a week.
So, Karan, what are you going to do for this patient now?
Sir, this patient requires a subtotal. We did a total thyroidectomy in this case, sir, but this patient requires a subtotal thyroidectomy, sir.
I think still there is a subtotal type of the thing is there.
No, sir. A near total thyroidectomy can be done for this patient, sir.
Don't get confused. You say you are done total thyroidectomy. He requires supplementary thyroxine. That should have been answered. Don't go on telling subtotal, near total, getting into problems at stage. No, whatever you already done over.
So when you are doing a total thyroidectomy, what are the most important structures you have to save?
Sir, the recurrent laryngeal nerve, sir, the parathyroid gland, sir, and the vascularity to the parathyroid, sir.
How do you identify the parathyroid gland?
Sir, in the
what are their constant anatomical sites? Do they vary or constant?
At the junction of the recurrent laryngeal nerve and the inferior thyroid artery, usually it is there, sir.
Okay, by the way, if you removed a tissue, you are not sure whether you have removed a parathyroid tissue or it's a fatty tissue or it's a what it is. What can you do at operation?
In the strap muscle, it can be, no.
If you want to differentiate between a parathyroid adenoma, a normal parathyroid, and a fat lobule, can you do something?
Frozen section, we can say, but
You don't have the
PTH we can send for, sir.
No, that is going to take a long time, you know. You want to know what is that tissue. You know what is water dip test?
No, sir. We can drop it in water. If it floats, it's fatty tissue. If it sinks, it's parathyroid.
Yeah, if it sinks, it's a parathyroid adenoma, and if it in between, it is a parathyroid normal tissue which is there. So by that, you can have an idea that whether you're dealt with a fatty lobule or it's a parathyroid tissue.
Any relation of the parathyroid gland in plane anterior and posterior to recurrent laryngeal nerves?
So it is anterior to the recurrent laryngeal nerves.
No, it is different superior and inferior. The superior are usually posterior, inferior are usually anterior.
Right.
Which parathyroids can be variable in their position, whether superior or inferior?
Superior parathyroid, sir.
Which one parathyroids develops along with the thymoma, thyroid gland? Sorry, thymus tissue?
The inferior parathyroid, sir.
Yeah, inferior thyroid is variable in position because it develops from the third pharyngeal pouch along with the thyroid thymus. So when the thymus goes down into the mediastinum, at the same time, even the inferior parathyroid can be variable in the position, whereas the superior parathyroid more or less is constant. What is the justification of total thyroidectomy in this patient?
Sir, male patient is there, age more than 40 years.
Okay.
Male patient, age more than 40 years. Size more than 1.5 centimeter is there.
Okay. Can you name some of the criteria, which names by short names?
Ages criteria, Ames criteria is there, sir.
Emesis and ages criteria. Okay.
Yes, sir.
I think we will come to the end in 5 minutes as we crossing the time. Can I request the faculty to give a closing remark? Dr. Paul sir, Dr. Neogi sir. I think Neogi sir was little away because of his commitments. Dr. Ishwar sir, Dr. Jayalal sir, Dr. Hitesh sir.
Sorry,
Okay.
I have just come back. I'm sorry, I had to go for the second case. I had some puja in the house.
We understand, sir. We understand.
The first case was very good. I think the discussion was excellent, and I enjoyed it as much as you did. So it's very good. Good standard discussion.
Thank you, sir. Thank you.
The good part is, even if the cases are repeated, even the faculties are enjoying. That's the best part of this discussion.
Senthil sir, I think we made you to listen to thyroid, I think.
Yeah,
Long
exactly.
time of your general surgery. Thank you for staying with us.
After a long, probably a couple of, maybe 15 years later, I'm listening to a thyroid discussion. I thank Dr. Kanagavel and the team. Sir, you have been very dedicated to the academics. I hope please continue the good work in the interest of the postgraduates. More than the CME, more than the CME, more than anything else, I think the clinical discussion is the most important thing, because with the availability of materials that's available in the open source in the form of internet, even teaching videos, I can say to some extent aids us. But what's lacking is case-based discussions, clinical discussions with the examiners. I think the postgraduates require this particular part of the teaching modules than anything else. So I congratulate you and hope to continue very good work that you have been doing it, sir. Hearty congratulations to you.
Sandil, we are sorry we didn't go for the minimal invasive thyroidectomy for your satisfaction.
Yeah. In fact, Professor Ishwar and the other esteemed faculty, we have been, closely associated in the minimal access forum. I think this is a forum which is of a very different kind in postgraduate teaching. In fact, if you remember, I have never uttered laparoscopic cystogastrostomy or cystectomy. It's a surgical intervention which we all concentrated, not the approach. So I think as others put in, I thoroughly enjoyed being part of this program, than the students. Thank you so much for making this.
Thank you. And Dr. Paul had to leave, I think, so he has mentioned in the group and is there. Kanna sir, right now for the coming week, we'll have for 8 to 10 only. Then we will try to see how it works, sir. Will that be fine, Kanna sir?
Yeah, sure.
Okay. Thank you, sir. Thank you, everyone. We wish you happy festival. And I have to put on record, we have Amazicon coming up in a week's time. And we have the HSICon coming up, and the National ASICon is going to be a big show. And I would welcome all the PGs to submit their abstracts and showcase their work, what has been done. So it is definitely important for you to get into the national platform at a young age, so that you get into brush shoulders with the pioneers and leaders of current year, and you go on to become leaders in future years. So I would request and recommend all of you to put up your thesis. In fact, IAGS has announced 1 lakh worth awards for the best thesis submitted as a PG. So the people should get use of it, and they should get into the leadership qualities, getting into the societies. That helps you to learn, helps you to share the knowledge. So November and December are going to be very busy months for academics. So I would request all the students to get into the respective societies and get benefited. So with that, on behalf of all the faculty here, I wish happy festival for all the students and the faculty. Once again, I thank all the faculty for contributing their wisdom here. And I also thank all the students who are on YouTube and who have been watching. And thank you one and all. We look forward next week at 8 p.m. Thank you. With the permission of the faculty, I sign off this evening.
Thank you, sir.
Happy Diwali to everyone.
Happy Diwali. Good night, sir.
Happy Diwali.